আমাদের ইয়ে So, dear doctor, am I audible? Dr. Jannatul. Dr. Jannatul, কি শুনতে পাচ্ছেন আমাকে?
জি জি।
Thank you very much for your kind response. Dr. Neha Singh, how are you?
I'm good, sir. Thank you.
Yeah. What's about your preparation?
Just going on, sir. Not able to do the personal studies, but yeah, lectures. Trying to attend the lectures at least, because I'm doing my residency right now, so it becomes quite difficult.
Okay, okay. Thank you very much. So, Dr. Neha Singh, Dr. Jannatul ma'am, and Blue Sky Timer. I don't know the name of your certificate. Can you hear me? আমাকে কি শুনতে পাচ্ছেন? Blue Sky Timer. যে আইডিটি আছে, কাইন্ডলি একটু রেসপন্স করবেন। ওকে, নো প্রবলেম। আমি অলওয়েজ রিকোয়েস্ট করব যে আপনাদের যে জুমের আইডিটিও আছে, আপনারা অনলাইনে যখন ক্লাস করবেন আপনাদের যে সার্টিফিকেট নেম আছে সেটা আপনারা চেঞ্জ করে নিলে আমাদের অ্যাডমিনদের পক্ষ থেকে এটা ম্যানেজ করা আরো ইজি হয়। So I hope, thank you very much. And first of all, I would like to welcome all of you to the Doctor's Academy. So Dr. Neha Singh and our other international candidates, sometimes I will talk in Bengali language, but it will not for you, especially whenever it is required, I will translate in English. Okay. So আপনাদের সকলকে স্বাগত জানাচ্ছি। ডক্টর জান্নাতুল ম্যাম কি আজকে থেকে জয়েন করেছেন?
না ভাইয়া, আমি আগে অনলাইন করতাম না, আজকেই প্রথম অনলাইন। আমি অফলাইন।
ও আচ্ছা, আপনি এমনিতে সেন্টারেই থাকতেন?
জি
জি জি, ওকে ওকে, ঠিক আছে। হ্যাঁ, so we are missing you here. আপনি এখানে থাকলে ভালো ছিল। সো এমনিতে নেক্সট ক্লাস থেকে আসতেছেন তো না সেন্টারে?
ইনশাআল্লাহ চেষ্টা করব।
ওকে ওকে, থ্যাংক ইউ। সো আমাদের সাথে আজকে জয়েন করেছেন আমাদের অনারেবল ক্যান্ডিডেটসরা আছেন। ডক্টর এমডি ফরকান আল আমিন আমাদের সামনে আছেন। ওকে, আরো আছেন ডক্টর আব্দুল আল মামুন, অনলাইনে মেবি কানেক্ট করার চেষ্টা করছেন। আমি একটু দেখার চেষ্টা করি। Okay, Dr. Saifullah Al Shamim, Dr. Kobir Dawan, maybe here. Okay, thank you very much. Dr. Ovijit Shah, once again. So I'd like to welcome all of you to the Doctor's Academy once again. So আমাদের যেটি হয়, definitely আমাদের একটা introductory part থাকে। আর introductory পার্টটা আমরা প্রতি সেশন ওয়াইজই সংক্ষিপ্ত আকার করে থাকি, এবং in introductory part we discuss some of the important information regarding your course syllabus, regarding the materials you are going to follow, regarding the mentor team. So some other details we are sharing in our introductory part. এবং আমি অবশ্যই হয়তো আমাদের অ্যাডমিনদের পক্ষ থেকে ডেফিনেটলি আপনাদের যে ই-লার্নিং প্ল্যাটফর্ম অ্যাক্সেসটা, ওটাতে আপনারা অ্যাক্সেস করতে পেরেছেন তো? ই-লার্নিং প্ল্যাটফর্মটা বুঝতে কোনো অসুবিধা হয়েছে in any extent if you are okay? So ওখানে আমাদের যে লাস্ট সেশনে একটা ইন্ট্রোডাক্টরি পার্ট আছে সেটা নিয়ে অলরেডি আপলোড করে দেওয়া আছে। সো আমাদের যারা অনলাইনে নতুন ক্যান্ডিডেটস আজকে যে জয়েন করছেন, আমি ওনাদেরকেও বলবো আপনারা কাইন্ডলি ইন্ট্রোডাক্টরি পার্টটা ওখান থেকে শেষ করে নেবেন, কারণ এই ইনফরমেশন গুলো রিপিট হয়। সো উই ডোন্ট ওয়ান্ট টু কনজিউম টাইম মোর এন্ড মোর। সো ওখানে মূলত যে বিষয়গুলো আলোচনা করা হয়, দেয়ার আর সাম ডিসকাশন রিগার্ডিং ইউর এক্সামিনেশন ফরম্যাট, like how many steps are in your MRCP UK journey, and the study materials which you are going to follow in your preparation. So আমাদের এই কোর্সটি যেটি এখন বর্তমানে যেহেতু আমাদের ইন্টারন্যাশনাল ক্যান্ডিডেটস আছে, এই ক্লাসটি কন্ডাক্ট হবে ইন ইংলিশ ল্যাঙ্গুয়েজ। ওকে, সো আপনাদের যে ইন্ট্রোডাক্টরি পার্টে অলরেডি ইন্ট্রোডাক্টরি ডিসকাশন আছে। আমি কিছু এডিশনাল দিক যেটি আমি উল্লেখ করার চেষ্টা করবো যে আজকে অন্ততপক্ষে আপনাদের জানা প্রয়োজন। সেক্ষেত্রে আপনারা দেখবেন ই লার্নিং প্ল্যাটফর্মে আমাদের যে আগের যারা ম্যান্টররা, অর্থাৎ আগের না বর্তমানে ম্যান্টর, বাট আগে বেঙ্গলি ক্লাস, বেঙ্গলি ল্যাঙ্গুয়েজও ক্লাস নিয়েছেন, অথবা কিছু অ্যাডভান্স ক্লাস আমরা ই লার্নিং প্ল্যাটফর্মে আজকে যে ক্লাসটি হবে সেটির পাশাপাশি আবার অ্যাভেল করে রাখি। এটার কারণ হচ্ছে কি, আপনি হয়তো এখানে আপনি কেউ আছেন, আমাদের অনারেবল ডক্টরস আছেন, মেবি অভিজিৎ শাহ 4 months or 6 month কোর্স, 6 month কোর্স, এবং আপনি সম্ভবত আছেন 4 months না, দ্যাটস ফাইন। সো ডক্টর কবির দেওয়ান স্যার আছেন 4 months এ। সো এই যে 4 months, 6 month এবং স্ট্যান্ডার্ড যে কোর্স ডিউরেশনটা আছে এটা হচ্ছে কি 8 months এ সাজানো হয়েছে। ডক্টর দীপাঞ্জন স্যার যখন জয়েন করেছেন তখন কোর্স ফরম্যাটটা 7 months এর ছিল। সো এখন এটাকে 1 month এক্সটেন্ড করা হয়েছে, বাট all other things are same, not increasing in fee structure, or it's not like that. But MRCP journey ta actually is a big journey. In context to other Royal Colleges of UK examinations, you need to study more, a little bit more, because medicine related study, you know from your medical MBBS life also, there are the more study you need. So that's why in preparation phase also, we have found that there are at least we need 4 additional classes there. Sometimes you will find that in your syllabus, there are the block tests like that, rheumatology, cardiology, and dermatology. And this 3 system is called block 1. And after then you will find that endocrinology or like that, respiratory or neurology is like the block 2. So after one block, in each system, you will go through an examination also after completion of your like that you have completed your rheumatology. So you will find a mock test in your e-learning platform. So after completion of 3 systems, we found that we need more discussion regarding some of your like the question bank also, like the past test or the recalls, past papers, or some of the advanced discussion regarding the block exam also will be there. So in earlier you have given the exam on specific system, but in block test you will give the 3 system at a time in a single examinations. So that's so that you can increase your efficiency to study more and more system in one single exam. So after then this block discussion, like that past papers discussion, like past test discussion, or you may call the recalls discussion, or the examination review, or the last 3 systems review discussion will be in this block class. So that's why we have added 4 additional classes also into your syllabus. So you will get the updated syllabus also there. So আপনারা যারা আজকে থেকে জার্নি শুরু করছেন এমআরসিপির জার্নির জন্য, ডেফিনেটলি আমাদের যে অনারেবল ম্যান্টরস টিম আছে, they are the very dedicated and very promising in that regard, because all the mentors have passed their recent diet and they know each and every scenario which are changing in recent track. So that's why you will get the best possible support, best possible guideline from the mentors. আমাদের এখানে এখন ডক্টর রিভা, জান্নাত আর রিভা ম্যাম ক্লাস শুরু করেছেন, ডক্টর হাবিবুর রহমান স্যার আছেন, ডক্টর অতনুদে আছেন, তারপর আমাদের আরো mentors team যারা আছেন, approximately 7 mentors in your mentors team, and they have the record also in their examinations in a high score. So that's why you will get a best support and best preparation from here. You just need to stick to your preparation, because your career journey, like that, if you say in MRCP UK, there are lots of thinking will arise in your mind in future also. Sometimes you may demotivated regarding others side talks or like that. Someone will inspire you, someone will demotivate you in related side talk. So in that regard, you need to stick to your preparation. You need to stick to your target, because you have the full opportunity to complete this degree within 3 years maximum if you target dedicatedly, because theoretically it is possible if you complete your preparation like the 6 or 7 months, 8 months, or you are going to sit for like the January 2024. If you pass this diet, you can attend immediately the next diet. If you have crossed your 2 years working experience or duration after your MBBS, you can attend any of your examination after even after part 1, you can also attend the clinical part without attending the part 2 written. So there is the open opportunity. Sometimes it happens that some of our honorable candidates are experienced in their clinical part very nicely. So they sometimes attend in clinical part first, and after then MRCP UK part 2 written. It happens, but we usually recommend to attend the course examination after completion part 1, then part 2 written, and then clinical part, because the same topic, same systems will be deeper, your knowledge divided, and you will know the each and every scenario in that written format also. So that's why this is very strongly recommended. আমি এখানে অনেক স্লাইড আছে, স্লাইডে যাব না, স্লাইডের ডিসকাশন অলরেডি ইউ উইল গেট ইন ইউর ই-লার্নিং প্ল্যাটফর্ম। সো ইন সামারি যে আপনাদের সিলেবাসটা নিয়ে আমি একটু শেয়ার করার চেষ্টা করছি। So these are our mentors profile. You'll find in our website or like that anywhere you have gone through. আমি জাস্ট সিলেবাসটাতে চলে যাচ্ছি। ডেফিনেটলি আপনি হয়তো সিলেবাসটা পেয়েছেন। সিলেবাসে আপনারা দেখবেন যে যেই সিস্টেমটা অলরেডি আমরা বলেছি যে আমাদের এটা সাইকেল ওয়াইজ চলতে থাকে। যেমন ধরুন আপনাদের আজকে থেকে যারা শুরু করছেন ওনাদের ক্লাসটা শুরু হচ্ছে কার্ডিওলজি থেকে, এবং আপনারা ব্লক 1-এ দেখবেন যে আমার তো রিউমাটোলজি করা হয়নি। সো এই রিউমাটোলজি ক্লাস এট দ্য এন্ড অফ সাইকেল ইউ উইল গেট। সো আপনার কার্ডিওলজি থেকে শুরু হচ্ছে, আপনি কার্ডিওলজি 1 to 4, দ্যাট মিনস 4 weeks ক্লাস আছে কার্ডিওলজির উপর, এবং কার্ডিওলজি ইজ ভেরি ইম্পর্টেন্ট সিস্টেম ইন ইউর প্রিপারেশন। সো কার্ডিওলজির পরবর্তীতে আপনার এক্সামিনেশন হবে, এবং এটা ব্লক ওয়াইজ আপনার সাইকেল ওয়াইজ চলতে থাকবে। এছাড়া আপনাদের যদি কোনো কোয়েরিজ আপনার মাইন্ড থেকে থাকে, অথবা আপনি মনে করেন আপনার জানা দরকার ক্লাস শুরু করার পূর্বে, কোনো কোয়েরিজ আছে আপনাদের কারো প্রিপারেশন রিলেটেড? ওকে, সো দ্যাটস ওয়াই আমি ইন সামারি এটাই বলবো, আপনি জাস্ট ফলো করেন আপনার যে লেকচার নোটস প্রোভাইড করেছে, কমপ্লিট লেকচার নোটস ইটস এ foundation of your preparation. Okay, after then you need to practice and one question bank, like you say the past test, and this question bank is very intensive, like 7,400 questions. It's a big volume. Already Dr. Kabir has already subscribed from us. It's a big volume. 24 systems are included into subsystem, like that clinical sciences. There are lots of subsystems there. So past test, and after this, the following the guidelines, and also another question bank also integrated into your question lecture notes also. So this is called you can say like the past medicine. So these are the main resources of your preparation. If you stick to your preparation or the material we are providing here, and this is very important e-learning platform. So you try to properly utilize the e-learning platform facilities, because each and every time you can get access to your e-learning platform whenever you want. You can revise it, repeat the lectures, repeat the examinations, and there are also question bank we have uploaded there, like on examination you will find an updated medical master class, you will also get there. So we will upload each and every material there, but first of all you need to complete your lecture notes, and then after the question bank, and after that if any additional material are provided from our mentors team, you just follow this. So best wishes from the Doctors Academy team. আর আপনারা যারা অবশ্যই সেন্টারে আছেন, আমরা ইন্সপায়ার করব, প্লিজ কাম টু দ্য সেন্টার। এটা আপনার যারা কোর্স ম্যাটরা আছে, অ্যাকচুয়ালি করোনা পরবর্তী সময়ে দেখা যায় গ্রিন রুট থেকে অনেকে অনলাইনে ক্লাস করে, গ্রিন রুট আছে বাসা। সো আপনারা চেষ্টা করবেন, দ্যাট উইল বি গিভেন এ গুড পুল। আর আপনারা যদি অন্য কোনো সময় মনে করেন আপনার স্টাডির জন্য অথবা আপনার গ্রুপ ক্লাস স্টাডি করতে চান, ইফ ইউ ওয়ান্ট টু সিট হিয়ার অর ডিসকাস সামথিং, সো দিস ক্লাসেস উইল বি ওপেন ফর ইউ এভরি টাইম। সো থ্যাংক ইউ ওয়ান্স এগেন, থ্যাংক ইউ ভেরি মাচ। আপনাদের যে কোনো ধরনের কোয়ারিজ ইন ফিউচার আপনাদের দরকার, অথবা যে কোনো ধরনের সাপোর্ট আপনারা আমাদের কাছে যোগাযোগ করবেন, আমাদের অ্যাডমিনরা সেভাবে সাপোর্ট প্রদান করে থাকবে। ইন শর্ট, ইউর সাকসেস উইল বি ডেফিনেটলি ইন ইউর হ্যান্ড if you dedicate it, if you are prepared by yourself. Just give in 6 months or 8 months course, you need to definitely give the 4 to 4 hours at least average time, if you immediately after 6 months you want to sit for the examinations. So this is the things, this is the summary, and no worries about your preparation. Okay, we will provide you each and every support. And don't worry, it will continue till support will continue till to your MRCP UK degree completion. So these are the things. So thank you very much once again, all of our honorable candidates also in online. So I'm just finishing my introductory part because today we have some new candidates in our course. So we have given some introduction to our honorable candidates in that regard. So thank you very much. Thank you all. Dr. Jannat Riva ma'am already has arrived at our center. She will start her class within a minute. Thank you. Thank you very much.
Okay, I hope I'm audible. Yes, okay. Hello, good evening. I'm Dr. Riva, one of the mentors here today. So today, I think a lot of people are joining us for the first time, and I welcome everybody to my class. So I'll just have a small introductory session, and then I'll proceed with our topic of discussion today, which is cardiology, okay? So I think Dr. Deep, we have already had a few classes before. So just to check, I can see two doctors sitting in front of me. Can you introduce yourself, please? You can just sit and just answer me. That's fine. Okay, doctor, what's your short name? Kobir. Dr. Kobir, okay. Kobir Dewan, right, okay. So what's your session, medical session? 2015 and 16, okay, amazing. So are you done with your internship?
Yes.
Okay, that's good. And are you working or doing any postgrad training at the moment? Okay, you want to take the preparation full on. Okay, any specific time goal, like you want to complete the MRCP part 1 by this time period? Next diet, October. So October diet is the final diet for 2023, right? Okay, that's great. And what about you, doctor?
Dr. Jannat, completed my MBBS in 2008 from Bangladesh Medical College Hospital. And now I am working as an RMO at Sword Hospital.
Okay, which department?
Orthopedics.
Orthopedics department. Okay. All right, no problem. So you have interest to do your further career in medicine. So I'm sure orthopedics was quite hellish for you. Maybe still is, but I'm not going to be judgmental. Are you new with any postgrad course or anything, or do you have some preparation before?
No.
Okay, all right, that's good, no problem. So when is your target to sit for the part 1?
January 2024.
So that's the first diet for 2024. All right, so I can see there are some participants, online participants. So I'll start with, I have been introduced with Dr. Neha Singh, and Dr. Jannat will be participating from online today, I believe. Can you hear me, Dr. Jannatul Naim Apu? Can you hear me? Okay. Dr. Neha Singh, am I audible?
Hello, ma'am. Yes, yes. I've just joined.
Okay, all right, no problem. So we're just having a bit of introductory session today because there are some new doctors who will be taking our first class. So that's why we're going to be, like discussing a bit details about how this exam is structured and everything. So you're here, that's very good to see and good to hear you back. And I can see Dr. Blue Sky Timer, is that our participant or is that a nickname? I don't know. Okay, so far we have these people, and I'm pretty sure we have some other doctors who will be joining us. But I think they will be taking this class from the e-online platform. All right, so first of all, I hope that to the one who are newly joining us, so the structure of the MRCP format, okay? So first of all, let's talk a bit about the MRCP exam. Why is it important and why you are planning to give for the MRCP? So before I give some feedback, I would just like to know from the newcomers, okay? So Dr. Obhijit, is it? Dr. Obhijit, okay, so can you tell me why exactly you want to do MRCP?
The what syllabus is interesting for me, and I wish to my career also for medicine side, and I also want to explore myself at outside country.
Okay.
For that reason,
Okay, that's a very smart move. So yes, most of the time, whenever we ask this question to most of the doctors, like, why exactly are you doing this MRCP course? Why? What's your intention behind this? A lot of people will have different reasons, but I can guarantee one thing: once you're done with all the 3 parts of MRCP, you would feel confident regarding diagnosing certain clinical conditions, as well as managing patient will be a very much easy for you. At the same time, with the help, I don't think that any other degree will actually give you this much of extensive exploration of all the medicine related topics. Like in our country, 2 most important degrees for medicine is FCPS, which is the fellowship, and the other one is the residency program or the MD. And I am currently in the FCPS training program. And personally, from my opinion, I think that you get to learn more if you are sticking with MRCP. So if your sole purpose is learning, and if you're doing the MRCP just on the basis of you want to enrich your knowledge and enhance your clinical skill, then it's a very, very good degree. I definitely will congratulate you, and I will tell you that kudos on that for choosing this pathway, because it's a very smart move. And MRCP is actually a worldwide recognized degree. So first of all, this is a postgraduate degree. This is not a medical licensing exam. And secondly, it has recognition in almost every country except for US and Canada. So it actually opens a lot of doors, especially in our postgrad medical life. So I think it's a very brilliant and smart move, and you can actually complete all the 3 parts within a very short period of time. And I hope everybody is, by this time, they're aware of how exactly the exam is formatted. So basically it has 2 parts, okay? So the part 1 is entirely MCQ based, and part 2 is divided into 2 groups, okay? The first one is the MRCP part 2 written, which is just like the MRCP part 1, but a bit more extensive and a bit more elaborative. And it also has like some diagrams, or it has a bit more complicated clinical scenarios incorporated into this. As well as you might need to go for the ECG interpretation of spirometry, interpretation of chest X-ray. Sometimes they do give echocardiography or cardiac catheterization interpretation. So if you want me to tell you what's exactly the main difference between MRCP part 1 and part 2 written examination, I will say that it's a matter of clinical experience, okay? So whatever you learn is plenty. It's sufficient for completing all the 3 parts. It's just the experience that will take you from part 1 to part 2 written, and from part 2 written to the clinical part, okay? So the final part is known as the PACES exam. And this one is the entire clinical setting, and you can sit for the PACES examination. Unfortunately, in Bangladesh, there is no PACES running center. However, you can appear as an international candidate in lots of other cities, for example, in India, Pakistan, Saudi Arabia, UK, any Middle East countries. And there are seats in Singapore and Brunei, Egypt. So there are plenty of international seats, as well as you can apply to the UK centers as well. And the number of UK centers are more compared to the international centers. Now let's talk about the general estimation of how much money do you require and what's the time estimation for each for completion of each of these parts. So regarding the time management, I would say it depends on from where you are starting. So which is why I ask this to most of my students. So at which step you will be starting your MRCP journey, that's very important. For example, if you are thinking of doing this right after your medical degree, like you haven't even done your internship, then there are certain ways you have to enhance your skills or enhance your knowledge. And if you're going for this exam right after finishing your internship, then of course your knowledge will be a bit more modified, and you don't need to like have much more time incorporated into your schedule. And finally, if you're already in a post-graduation training, so you will obviously need a little bit less time compared to the previous categories that I've mentioned. And finally, if you're working full-time and if you're like already done with a post-graduation training, and then it will definitely require you a little bit less time, but at the same time, you have lots of responsibilities now. Like maybe you have an entire family dependent on you, you're going for the chamber practice, you might be, going for some other sources of income, or might be something else. Like we are all adults, we have different business in our life. So there is no easy way of like saying how much time exactly you need, but roughly I would say 6 months preparation for a beginner to intermediate level. And if you already have somewhat exposure or somewhat of training experience, or if you have some working experience in the clinical sector, or maybe even a part 1 of a clinical examination from our country's perspective, then I would say you need only like 3 months. Okay, so 3 months of solid preparation for part 1 is enough. And now let's talk about how much time do you need for the part 2 examination. The correct way would be as soon as you are done with the part 1, okay? So immediately go for the second part, the part 2 written examination. Why is it important? Because you will try to like go up from whatever preparation you took for the part 1 examination, okay? So if you go for like, maybe if you dilly-dally your decision, like, okay, I just finished part 1, so I want to like take a bit of time to myself, I want to chill, I want to maybe focus on some other things, and MRCP is not your not your priority. So you're thinking maybe I'll just take 6 months to 1 year break, then actually this will actually decrease your chances of passing at one go. I'll tell you why. Because you have to start from the bottom again. So whatever you learned from your part 1, you utilize that, and then you enhance your clinical knowledge by solving more in-depth questions for the part 2 written examination. Because passing in part 2 written can sometimes, for some people, it can be more difficult compared to the clinical examination, because this actually entails you to learn more, to do more, to achieve more. And the scenarios are a bit more complicated. So whenever you're trying to go for the single best answer out of 5, then you'll see you're always stuck in between 2 answers, okay? For the part 1 examination, no such critical confusion will arise. But for the part 2 written, there will be a lot of confusion. So that's why in order to get rid of that confusion, you need a solid preparation, and best possible ways, as soon as possible, you're done with the part 1, book for the part 2 written examination. So in my opinion, it's best to complete the part 2 written examination within 3 to 6 months of part 1 completion, okay? Not more than that. And now let's talk about, so I have done part 1 and part 2 written examination, congratulations. Now, if you're thinking of sitting for the PACES, which is the final part of the MRCP route, So I don't know who else, how many of you play the video games? There are different levels of beating the villain. So the boss level, you have to be entirely prepared for that. You have to have all of your life stored. You have to have all of the potions and the magic potions and maybe the highest or the longest blade or whatever in order to like slaughter that villain. So this is exactly the same thing. Paces from the outside kind of looks very benign, very normal. Like you feel like, okay, maybe I can just like ditch the examiners by looking more professional, by looking sharp, by like with the help of my accent or something. But here is something very important. PACES is not an English language test. This is not an exam where they will see your smartness. Of course, smartness plays an important role, and your physical appearance and how confident you are with dealing the situation, with dealing the patient, everything is important. But then again, ultimately, what matters the most is how clinically sound you are, okay? So if you diagnose a case of aortic stenosis, maybe for murmur. So if you are not able to pick this up from the patient, and if you wrongly diagnose the patient as a case of mitral regurgitation, then of course you're going to lose mark here, okay? No matter how much confident or no matter how much smart you look to the examiner, you're going to lose mark. If you're not able to diagnose a certain clinical condition, okay? So the examiners will not be happy no matter how much smart or posh or sophisticated you appear to be during your examination. So that's why this one is most tricky. You have to be very professional. You have to be very clinically sound. And whatever you learn from the part 1 or the part 2 written examination, this is the field where you apply it, okay? PACES is the field where you can show your clinical skills, where you can show your clinical knowledge. And if you ask me what's the time, I don't know that I don't know the answer, okay? Because for some people, you can do it within 6 months of completing the part 2 written, but somewhat clinical training or clinical experience is a mandatory to pass PACES. You cannot pass PACES without having any clinical training or clinical experience, okay? So that's why you have to see tons of patients, you have to practice and practice and practice. And maybe when the luck favors you and all the cases seem, like doable, that's a very good time estimation. However, I don't want to make you disappointed. You're just starting the journey. So I will say roughly 6 months, 1 year of completing your part 2 written examination. But in RCP, according to the RCP, they usually recommend you to take 2 years of clinical training before sitting for the PACES examination. However, this is not a strict rule. You can apply as early as possible. There is no clean-cut barrier that you need to follow. So it depends on your capabilities, but I would say play it smart. Do not waste your money on a bare minimum preparation. So maybe 6 months to 1 year is the best possible the time period or time frame. Okay, now let's talk about the money, the amount of money that you would require. So for part 1 and part 2 written examination, I'm not sure of the current estimated rate, but this is pretty much doable. Like in Bangladeshi taka or Bangladeshi currency, it's usually in between 65 to 75,000, maybe plus minus, depends on the pound rate, of course. But for the PACES examination, however, you need to it has a separate for UK center rate, and it's a bit different for the international center. So for the international center, this is roughly around £1,202, and for the UK center, this was £657. But then again, if you, as an international medical graduate, if you book for the visa, if you buy the plane ticket, round ticket, and if you spend in the UK any exam center, any hotels near the exam center, so that's gonna maybe cost you twice the amount it would cost you in the international center. So you have to choose in between these two, pros and cons and everything. So I think I have pretty much started with a very gloomy news. I don't want to make you disheartened. This is doable, don't worry. Actually, within a very short period of time, within maybe 2 to 3 years, all the 3 parts can be done. And if you're playing it smart and if you're learning smart, then it's a very doable and very easy exam. Okay, so and since our topic of discussion today is cardiology, so the structure of MRCP Part 1, just a gist of it. So MRCP Part 1 will be held in one single day, all right? And once you apply for it, and then you have to pay for the exam, you have to have an RCP account. And then how can you create that RCP account? Just type on the Google like mrcp.uk, and if you click the first link, then you'll be able, it will redirect you to a page, and then you'll be able to, like fill in different boxes. Okay. All right. So there are different boxes requiring your information, address, and blah, blah, blah. And after you're done with that, they will require a primary medical qualification that needs to be notarized either by the British Council or any of the governing authorities. In our country, if you're from Bangladesh, then this can be done in the British Council, which is located in the Fuller Road, or the notary can be done from the press club, in front of the press club. Okay, so there are different the advocate assistants there, so they can notarize each of these documents for like 30-40 taka or something like that. So you need to scan that and send it to the primary medical qualification member, or so they have a separate email address. You have to send it for the verification, and after the verification, you can open up an RCP account. And when the application time period opens, you'd be just expected to, like apply for the exam. And then they will give maybe 7 to 10 days, within which period you can, like make for the payment. And 1 month before the examination starts, they will send you the admission document, which will be like the admission letter. You have to show up at the exam center with the admission document. Along with that, you have to have an identity. It's usually the passport, or sometimes they also, like accept driving license. So it depends on the center. And in our country, there are actually 4 centers for the Part 1 examination. In Dhaka, there are 3 centers. So one is located in the Dhanmondi area, and another one is the Oxford International School, and the other one is the British Council. And sometimes they change the British Council venue to the BICC Center. And in Chittagong, there is 1 center. Okay, so that's altogether 4 centers running. So there are 4 different diets for the Part 1 examination. And there are 2 papers for Part 1, paper A and paper B. Each of the paper will have 100 questions, so total 200 questions. So each of the paper, you will have 3 hours, and there will be half an hour to 45 minutes of break. And then the paper B will start. So it's a day-long process. There is a very high chances that you might feel a very dainty or very dizzy. So it's advised that you have your, like beauty sleep the night before. Also, like you can keep some chocolate or some coffee with you so that you don't really run out of energy. And most of the important systems, they usually have 14 questions. Okay, so 14 questions from cardiology. So we will be aiming for the 14 questions from cardiology in the next 4 sessions. So we will do the cardiology in total 4 sessions. So far, does anybody of you have any question or queries for me at the moment? Please let me know. Any question? Okay, so I think.
Hello, madam.
Yes.
I have
Hello?
queries on behalf of all of our candidates from. So can you give some lights regarding or focus the study materials which they will follow on the whole systems or like specific system, and the study materials which we are providing, or the mentors are giving the lectures, some notes and explanation. Is it enough to complete or pass the examination? And that is, so if you give some light on that matter.
Okay, thank you so much for this question. I will definitely tell you, I actually forgot about this particular portion. So thank you for reminding this to me. So the materials that are very important. First of all, the way you can prepare yourself. I have been telling this to most of my students in the last few sessions. Like, first of all, the lecture note that is provided to you, this will kind of look like this. This is the offline version. You might already have the online version as well, the PDF copy. So this is entirely just like the past medicine and the Maghrabi. So you don't really need to go through separately in order to, like start your preparation. Go through the lecture note, whatever I'm discussing in the lecture, try to follow that. And then once you're done with the lecture, once you go back to your home, then, go through the topics which I have discussed or some other mentors have discussed. And then there is some question answer in the bottom, like towards the later part of the, with explanation in the lecture notes, and try to like go by the topics and solve the questions related to the topics, and then you'll be able to see how many of them you got right. Okay, so that's the very initial part. And then after each of the lectures are completed, for example, after the 4 classes of cardiology, you would be expected to be done with this book, okay, including the question answer. And then you will be given a mock, okay, based on the cardiology section. So for mock preparation, I think this book is enough. Along with the question answer session, you can maybe try to incorporate some, solve some question from the past test question bank. So I think in currently there are several question bank, but if you want me to, like grade which one is most important, I would definitely say past test question bank is most important, because this is not too easy, this is not too difficult, this has very standard structured question, and most of the questions actually have very much close similarity with the past test question bank. Okay, past medicine, okay, I think it's very important to have your knowledge build up in the first instance. So which is why I think past medicine question bank is also important, because you cannot start with something difficult. In that way, you kind of hinder yourself from learning more. So past medicine question bank, you don't have to buy separately, or you don't have to solve it separately, because if you're done with the lecture note, if you follow the lectures properly, you'll be done with Maghrabi and past medicine eventually. Okay. So after this lecture note, I will suggest past test. And if you have some time, like for example, one of our doctors, he will be going for the exam in the first diet in next year, right? So you have some time. So you can maybe, like level up your knowledge by aiming for the on exam question bank. So if on exam is only when you are done with our lecture notes, our mocks, and our past test question bank, and then you can proceed on to, like solving on exam. If you're aiming to give this exam in maybe like in the 3rd or the 4th diet for this year, on exam is not really recommended, maybe plus minus for the final diet. But on exam questions are a little bit on the tough side, and I don't think that you would face that much, like all the questions are not going to be tough. Maybe if you combine from paper A and paper B, maybe 5 to 10 questions would be very difficult to solve, but that will not make you fail in an exam. So my theory is try to focus on the important topics, on the standard question, on the common question first. Okay, do not get yourself overboard with anticipation of complicated scenarios. Okay, those are rare. So after once you're done with acquiring the knowledge that is required for you to pass this exam, do not bombard yourself with too many complicated scenarios. Okay, those are very rare, maybe 5 to 10 questions altogether from both the papers. So that's why I will just say, like, go through our lecture notes, prepare yourself well, and solve the past test question bank, and then revision. Revision is the key here. If you just revise yourself with our provided lecture note and the question banks as well as the past test, that is enough for the part 1 examination. No other material is needed. And as for the reference book, I would put from easiest to hardest. So easiest reference book, which helped me a lot, was the Suda Medicine by Dr. Hani. It's an Egyptian author, so very precise and concise information are written there. I think it's an excellent book to, like revise just a couple of days before the actual examination, because all the informations are in a very gist form. And for further clarification, you can check Oxford Handbook of Clinical Medicine, but only for the acute medicine portion. And if you have some further confusion, then only go through that book, but no need to go separately through Maghrabi or past medicine if you are doing our lectures and everything properly. Okay, so I hope everybody is a bit clear on the resource section, right? Okay.
Ma'am, could you please read the name? Sudha
Okay.
Medicine. Did you say Sudha Medicine?
All right. Okay. So for question bank, most important one is cost test. Go through this twice and solve the lecture notes that we provide with you and the question bank that are given to you towards the end of the lecture notes. Okay, that is given by the Doctor Academy lecture notes. So for question bank purpose, these are perfectly fine. If you have time, then you can go through on exam. That's also a question bank. And for the reference book, I think our lecture note is enough. And for the gist, I would suggest Sudha Medicine, SUDA, Sudha Medicine by Dr. Hani. It's an Egyptian author's book. And another important and authentic information book would be Oxford Handbook of Clinical Medicine. It's a very small book.
Got it, ma'am. Thank you.
Okay, all right. So thank you. I think we will start with our class today, cardiology. If you have so far any question, please let me know, okay? Okay, I hope my screen is visible to everybody. Cardiology, I think a lot of people are scared of cardiology for some reason. If you can just, anybody, whoever is participating today, can you give me a reason why? Dr. Deep, can you tell me why a lot of people might be scared of cardiology preparation? Do you find cardiology easy or hard or medium? Medium, okay. So what do you think that the most common pitfalls might be for other candidates or maybe anyone who's going for some exam?
Maybe they think the physiology is not clear to them sometimes. That could be a tough thing, and most of the teachers love the subject, so they get into the nooks and cranny of the topics. So sometimes that can be quite challenging.
Okay, all right.
Basic things are
Actually, for cardiology, here's the thing. Yes, Dr. Neha, I think.
Yeah, I feel diagnosis is differential diagnosis, and then final diagnosis is very difficult at times to rule out the cases. And secondly, reading the ECG and interpretation is much more difficult, I feel, at times.
Okay. Yes, I think this is one of the most feared topic for almost everybody, like no matter where you're from. So ECG is something that we all fear. But the good news is you don't have to be worried about the ECG finding for the part 1 examination, okay? For part 2, definitely, but there are some tips and tricks, like they do not really go for, if you're doing FCPS in cardiology, if you're doing residence in cardiology, then there are so many criterias. Like once you're starting with ECG, it would be easier for you to comment on, okay, this is a case of ST elevation MI. So this is a case of non-ST elevated MI. This is a case of right bundle branch block. This is left bundle branch block. This is RAD, LAD, blah, blah, blah. But then again, once you keep on, studying more, then you'll be able to see like it's not that easy to diagnose, because with left bundle branch block, it's very difficult to comment whether there is a myocardial infarction or not. So you have to go for this Garbosa criteria. There is modified Garbosa criteria. Like there are so many criteria, okay? So we are not going to go through the details of that because that can be tedious. For MRCP purpose, ECG findings are very much straightforward. The obvious finding will be there. Maybe sometimes even they just give the rhythm strip so that the pathological finding is very much visible to you. And another easy thing on the side of MRCP purpose, I would say that the question stem gives you a lot of clues. Like you might be confused with the ECG reading, but from the stem, you can get the clue, okay? So that's how the questions are actually a bit easier for the MRCP compared to the other traditional cardiology exam, okay? And as for the diagnosis and the differentials, of course, I'm here to help you with that. And Dr. Deep, he mentioned that the physiology, and personally, even I am scared of this actually. Sometimes the physiological changes and correlating with them with the, findings as well as the diagnosis can be very tedious. But then again, for MRCP purpose, as long as you're not doing any specialty training in cardiology, you don't have to go through details of it. So we will just try to, execute the part 1 And that should be our worry, one thing at a time. Like, we'll take baby steps, okay? So no need to worry about this. So I'll start with cardiology and how many topics are there. So in total question, you can expect 14 questions, okay? So if you imagine, like, I'm very bad at drawing, like most of my students already know that I'm a terrible drawer. So if you know, like draw the heart like this. All right, so so from here, this is a very rough drawing of heart, okay? So if you go from like outside to inside, the pathologies, okay? So we will divide our pathologies. So there is pericarditis, the disease of the myocardium, myocarditis, very MRCP hot topic, or the myopathies, myocarditis, whatever you say. Then there is the lining or the endocarditis. Endocarditis topics are basically valve abnormalities, infective endocarditis, and rheumatic heart disease or rheumatic fever. Okay, and then after that, you get some pathological findings with the electrical conduction abnormality. So those are within the cardiac arrhythmia portion. They can be on broader heading. They can be either supraventricular or the ventricular. Okay, and then they have too many classification, but for my easy, you know, like understanding, I usually divide arrhythmia into two broad classification. One is the supraventricular and the ventricular, and narrow complex and broad complex. Okay, like do not overcomplicate things. And then after that, the electrical abnormality, you get the vessel pathology. Okay, so important one is the pulmonary hypertension, and the other one is aortopathy. So between the pulmonary hypertension is also a hot topic, and among the aortopathy, it can be either in the form of dissection or coarctation. There are other pathologies like as well as aneurysm, but I'm just trying to write down the important topics, okay? And then after that, you can see like there are some structures here and there. So there is valvopathy, which I have already will be discussing within the endocarditis section or the endocardium pathology. And then there are some congenital abnormalities like atrial septal defect, ventricular septal defect, and some other congenital heart disease. So in together, congenital heart disease. So now the cardiology system does not seem that complicated, does it? Right? So you can just divide all these portions one by one. So today I will actually go through just like the ones that are given in the lecture note. So I will start with the basics of cardiology, and rest of the physiology that are related to cardiology or the cardioanatomy will they have already been covered in the clinical science. So for startup, we will start with the basic cardiology that are important for you in the clinical cardiology section, okay? So in the action potential or the cardiac action potential, I think this, we all read about this back in our second, I think medical first or second year. And if you remember the photo, this was something like this, okay? So you can see this is the basement membrane potential or the resting membrane potential. So if you divide the stage like 0, 1, 2, 3, 4. So stage 0 is the basic, the rapid depolarization because of the sodium abnormality. All right. I think the picture is already given, so I'll just go to that. Yeah, I think this one is better actually. Okay, so as you can see, there is rapid sodium influx, okay, in the stage 0, causing rapid depolarization, and stage 1 is basically the potassium is slowly coming out of the cell. Okay, so that's basically the early repolarization. And plateau phase is most important. This is basically influx of the calcium channel. Okay, so there are some calcium receptors which makes the cardiac muscle different from the skeletal muscle, this plateau phase. Okay, so after, if there was no plateau phase, what would happen? Okay, so our heart would not be able to pump blood in a very sustained or systematic way. Okay, so it will be just rapid firing and defiring, rapid firing and defiring, which would be pathological. None of us would be able to survive. So you see the plateau phase of the cardiac action potential is very, very important, which is why the RCP loves it as well. And which abnormality, which electrolyte is responsible? Calcium. Okay, I think there is the receptor written here also, the L-type calcium. And here, just try to like give the yellow marker or something underneath the phase 2, which is the plateau phase, indicating the slow influx of the calcium. And the final repolarization is rest of the potassium will be getting out, so causing the final repolarization. And stage 4 is basically you can see the action potential coming back to the resting or the basement membrane potential. That is the stage 4. All right. So the cardiac muscle remains contracted. Okay, that's fine. I think there is some small information regarding the conduction velocity. Like this is not important, maybe for true false purpose, this can come, okay? Like which has the highest velocity and everything, Purkinje fibers, okay? So the normal variant, ECG changes, normal variant seen in athletes. This is important. Remember, they might confuse you with questions like, which one is not seen in the ECG changes of a normal, healthy athlete, okay? So you can see, like, if you remember, there is sinus bradycardia is common, junctional rhythm, first degree heart block, even type 2 or Wenckebach phenomenon of the second degree heart block. These are common variant. Which one is not common? That's LB, sorry. That's actually LBBB. Even in right bundle branch block, this can be sometimes normal individual, okay? This can happen in the normal individuals. But whenever you're getting a left bundle branch block pattern in an ECG, this is almost always pathological, remember this. So our next topic is also very simple. What are the coronary artery territories and what does the ECG lead signify? So if you remember the normal ECG, how does it look? Okay, so you will see like there is lead 1, lead 2, lead 3, and limb leads are AVF, AVL, and AVR. And their chest leads are precordial leads like V1 to V6. Okay, so in AVR, usually we do not really pay much attention because all of the deflections or reflections you're getting will be entirely opposite side because this is viewing the heart from the opposite direction, okay? So that's why AVR is not the significant except for one condition. I will tell this about in a bit later on, which I think will be very much handy for the part 2 written examination for you guys. So if you see like the anterior leads, there is ST elevation or depression, then the anterior, you have to remember the anatomy of the heart, okay? So the anterior portion of the heart is supplied by the left anterior descending arteries or the LAD. So I don't know if you remember from my clinical class or maybe people who are, like participating for the first time. So there are 2 coronary sinuses, okay? The left coronary sinus and the right coronary sinus. And then there is also another sinus, but this is non-functioning or non-dominant sinus. So no artery will be arising from there. So from the left coronary sinus, there is this huge vessel coming out. This one is known as the left main coronary artery. And the left main coronary artery will actually continue as left anterior descending or the LAD. And this will actually, circle the heart in this direction. This is known as the left circumflex artery. And it has several other divisions like proximal, middle, and distal, but this is not that important for part 1, part 2. Maybe if you're ever doing the angiogram procedure, maybe that's when you need the anatomy entirely. And from the RCA, you get the only artery that is the right anterior descending artery. So it runs down as usually in the back of the heart, okay, and towards the apex, but from the back side. So this is usually the front side and that runs in the back side. All right, so coming back to the anterior or the precordial leads, it either indicates that there is anterior ischemia, or if there is extensive, like V1 to V4, so V1 to V2 or 3 is anterior, okay? V3 and V4, this is septal territory, and V5 and V6, that usually indicates lateral side, okay? So altogether, that is anterolateral. Okay, so if there is anterolateral involvement, that is huge ischemia is going on. So that usually indicates the LAD has been impacted, okay? From the lateral side, there is some portion of the LCX territory and also some branches from the RCA territory as well. If you get like maybe one and also AVL and V5 to V6, then that means the lateral territory has been compromised. So which artery is responsible for that? The left circumflex artery. So if you just, like go back and forth of this particular box, you don't really need to like imagine, you don't have to cram this information, just imagine the heart and the arteries, and then it will be easier for you to imagine which territory has been involved. Like in here, the most common one we face in our clinical practice is the inferior MI, okay? Inferior MI, we all know that 2, 3 AVF, these are the leads that will represent the inferior territory. And inferior territory is invariably due to the right coronary artery, okay? So here you can see the lateral portion, only the left circumflex. Anterolateral, okay, it's a combination of bit of both, maybe LAD and left circumflex together. And posterior is mostly left circumflex as well as the right coronary, which I have, drawn in the previous here, like the RCA and also some tribute branches from the LCX territory. So just imagine the cardiac anatomy a bit, and not that too many complicated questions will come from this box. Just simplified view, okay? All right. So axis deviation is important in a sense that it's easy to remember which axis deviation, which pathological condition causes which axis deviation. Basically, all the left heart pathology will cause left axis deviation, and most of the right heart pathology will cause right axis deviation. So what are the confusing parts? Okay, I'll tell you what. The WPW syndrome, the right-sided accessory pathway. So see the word right, okay? So this will cause left axis deviation. They will actually give you true or false statement, and this is actually the portion where you might have some confusion. And previously I have told you that whenever there is some confusing information, RCP will actually pick up on that. All right. So, and you can see that there is the word hyperkalemia. They might change it to hypokalemia. And then also you can see in the ostium primum ASD defect, which is the atrial septal defect. There are two varieties, one is the ostium primum and the ostium secundum. The ostium secundum is the most common variety, and primum is a bit of less common variety. So, and ASD usually causes pressure in the right side, okay? So consider ASD as a right side pathology. So that's why you can see that whatever the less common cause of ASD will cause left axis deviation. It should have caused right axis deviation, which occurs in the secundum defect. I hope you guys are following me, or am I talking too fast? Please let me know. Are you guys clear? Okay. So as I mentioned, like the common pitfalls here would be the site of accessory pathway. So right side accessory pathway will cause left axis deviation. Hyperkalemia, they might change it to hypokalemia. Ostium primum can be secundum, and obese patient will be tall or lean and thin patient, okay? So that's why just try to remember only one side. You either give focus on what are the causes for left axis deviation, or you either focus on what are the causes of right axis deviation, okay? So do not try to like remember both of them, because in that way you will just mess up. Try to focus on one, either LAD or the causes of RAD. All right, so PR interval, invariably, what does the PR interval is normally 0.12 to 0.20. That's the normal duration. And whenever it actually crosses 0.2 to maybe 0.22, then that's what indicates first degree heart block, okay, or the increased PR interval. So causes for a prolonged PR interval, again, it's quite important. You can see that hypokalemia can cause increase in the PR interval or prolonged PR interval, okay? So they will change it to hyperkalemia. So that's why I think it's important to, you know, like separately go through the ECG changes for hyper and hypokalemia. We have all gone through this back in our undergrad level, as well as this has been discussed thoroughly in the clinical science portion. So just when you go back to your home, try to like, you know, like see the notes, or maybe even if you have the physiology book with you, then go through what are the ECG changes, or maybe type it on the Google, it's very easy. Like what are the ECG changes for hyperkalemia and what are the ECG changes for hypokalemia? And if you go through in that way, then you'll never be able to forget like what are the causes of prolonged PR interval. Okay, and this one is quite important. I'll tell you why. The aortic root pathology or the abscess secondary to endocarditis, because there might be question like a patient with infective endocarditis, non-refractory to antibiotic treatment, which of the following parameter is most important to take you into decision of going for surgery? Okay, so when we will discuss about the infective endocarditis, I'll tell a bit more about this. So they might not give you aortic root abscess directly. They might give you any options like prolongation of persistent prolongation of PR interval, okay? So you see the options will not be too much out there. So you have to pick up the signs and everything, whatever you learned, okay? So I'll discuss this again a bit later on. So short PR interval, only one condition, WPW syndrome, that's all. And they're saying that hyperkalemia can cause prolonged PR interval, but I would say don't try to remember this because you would actually, you know, like get it messed up. Just remember it's always low potassium, low potassium, low potassium that will cause first degree heart block. All right, so complete heart block features are very important. So bradycardia is the commonest ECG finding for a complete heart block, okay? So if I can draw down, how does a complete heart block look like on the ECG paper? So what are the causes for complete heart block? Pretty much anything and everything, right? Any medication like digoxin toxicity, ischemic heart disease, especially the inferior MI can easily lead towards complete heart block. Also the anterior MI does that as well, but I think sinus bradycardia is more common in the inferior MI, so thereby leading towards complete heart block. When the second or second degree heart block may progress to complete heart block, okay? And there are some cardiac procedure or during anesthesia, some people who have structural heart disease, they might experience complete heart block. And other condition, I think, apart from the cardiological condition, important ones to be remembered is some infective condition like Lyme disease. This is important. And from the neurological condition, myotonic dystrophy, okay? So I think it's important that you remember, because in myotonic dystrophy, one of the most common mode of mortality is heart block or maybe different cardiac arrhythmia. So in the ECG, what does the ECG look like for first degree, for second degree, or for complete heart block? So first degree is basically prolongation of the PR interval and nothing more than that. So second degree heart block is further two type 1, sorry, type 2A or type 2B. Type 2A is also known as the Wenkebeck, or a lot of people call it like Mobitz type 1. And this one is known as the Mobitz type 2. Okay, so what happens is the Mobitz type 1 or Wenkebeck phenomenon. So in the ECG, so there is just like prolonged PR interval, like, okay, sorry about that. So if you draw like this is the P and this is Q and this is R, S, T, okay? So then the next one comes the P, Q, T, something like that. So this is like the normal one, okay? And for the MOBITs, for the type 1, or the first degree heart block, so the PR interval, this is the P and this is the R. So this will actually significantly lengthen. So the next one, the TP segment will be normal, then the P, and this is Q, this is R, this is S. All right, I hope you can see like the distance between the PR here, and then this is gradually prolonging, okay? You can see that this is another prolongation. So this is prolonged PR interval followed by, and then this will follow like a drop. You will not get any QRS complex in the next beat. So, and then it will go on to the previous rhythm again. So after some like normal, pause, normal, pause. And in between, all the PR prolongation, all the PR interval will be prolonged. That's the first degree heart block, okay? And the second degree heart block is the PR interval is constant. Here you can see like this is increasing one lead after another, and there is a pause, okay? So that's the type 1 or the MOBITS type 1. And here, in the second degree, you can see so do you see like not all P waves are following a QRS complex, okay? But the PR interval, however, will be fixed. So if you think this is the X distance, this is the X, this will be the X, and the further one will be the X distance. So, but then again, this will be more than 0.2, okay? So, and here, if it is 0.2, now you can see 0.3, then 0.4, and then there is the one sinus pause, okay? So this is the basic difference between the type 1 and the type 2 second degree heart block. And for the third degree heart block, it's very easy. So if you get a rhythm strip and you see like, this is something that looks like this. As you can see, already see like the from one R to another, the distance is so much, you can already tell that this is bradycardia, okay? That's number 1. Number 2, not all the P waves are following a QRS complex. Like in here, you can see that there is no QRS complex. So that's AV dissociation. And you'll see, like, of course, I haven't really drawn an accurate diagram here, but the P and the, imagine there is a P. So the PP intervals will be constant from one P, the other P. This difference will be constant, and the RR interval will be constant, but the PR interval, so from the P and then the R interval will vary, okay? Because there is a drop beat here. So obviously the PP interval is static. The RR interval is static, but the PR interval not static, as well as there is features of AV dissociation. So not P waves will be followed by QRS complex. At the same time, you can expect that there is sinus bradycardia, okay? So these are the findings for complete heart block. Even if you're not able to pick up the first or the second degree heart block from the ECG, never miss a complete heart block. It's very easy to, like diagnose the complete heart block. So causes for complete heart block, I've already mentioned. So what are the signs you can expect the patient to be presented with a complete heart block? So what's the commonest complaint a person might tell you when a patient is having complete heart block? Any idea, Dr. Kobir? Can you tell me what's the commonest presentation of a heart block or complete heart block?
Syncope.
Syncope, exactly, very good. And how the bradycardia will manifest?
Dyspnea on rest.
Dyspnea, okay, fine, yes,
On
dyspnea.
rest. Dyspnea on
rest.
rest as well.
Okay, as well as dizziness, syncope, dizziness, the patient, In our country, most of the time, the patient will be telling you, I don't feel good, doctor. I feel like I'm falling, okay? I feel like my head is spinning. I feel like I'm blurry. My vision is becoming blurry. So that will actually make the patient fatigued or tired. So that will cause increased workout within the pulmonary vasculature, thereby causing tiredness, okay? So yes, Dr. Kobir, you're very much correct. Syncope is the first presentation, as well as Dr. Neha. Shortness of breath or dyspnea on rest can be a presentation, as well as dizziness, blurriness, or fatigue. These are the commonest presentation of a complete heart block. And complete heart block is with any underlying pathology, like if you don't get any ischemic heart disease, if you don't get an infective cause, if you don't get any neurological condition, no structural abnormality, then can you tell me a very common cause for complete heart block?
It can be because of genetic cause as well.
Genetic causes, anything that's more common in our clinical practice? Aged patient, more than 80, common causes sick sinus syndrome. It's very common because of the degenerative or the calcification going on within the heart and the vessels, also within the conduction system. So a lot of people will be aged population, like more than 75 or 80 years. Because of the degeneration, they might present as complete heart block, and the diagnosis is known as sick sinus syndrome. So we will discuss about the sick sinus syndrome in our second class, because I will entail the cardiac arrhythmia then. But for now, just remember, like, old age is a very important risk factor for complete heart block. All right, so what are the physical signs? Actually, physical sign, okay, pulse, you can get that there is bradycardia. You might, like get some drop beats as well in the pulse, as well as the JVP. Okay, so the JVP will be raised.
Raised.
Yes, JVP will be raised, and there are two different types of JVP variation you can expect in a complete heart block. One is the Canon A wave. I will discuss about the JVP form in a bit. And the other one is irregular JVP. No other cause behind irregular JVP except for complete heart block. The only reason for irregular JVP is complete heart block. Okay, remember this. All right, so we have discussed about the pulse and the JVP. What about the blood pressure? Can anybody tell me what's the change for the blood pressure? So low blood pressure, hypotension, yes. Another important one is white pulse pressure, okay? Yeah. So white pulse pressure and low blood pressure, these are the two common manifestation or findings in the blood pressure you might expect in a patient with complete heart block. All right, so, and in the precordium, is there anything that you can expect in a patient with complete heart block? Only one thing in the precordium that you can expect in complete heart block. Anyone? Heart sound will be? Okay, I appreciate your way of thinking. Actually, yes, it's a very logical thinking that the heart sound will be diminished. But when the heart sound diminished, it usually happens when there is pericardial effusion or tamponade. Other than that, heart sound will not be diminished, but the first heart sound will be variable. So variable first heart sound can be found in only two conditions, okay? One is complete heart block, and the most important one is atrial fibrillation. So you'll see, like, atrial fibrillation and complete heart block, they kind of can present in a very similar manner, okay? So just remember, what are the differential for variable first heart sound is atrial fibrillation and the complete heart block. So that's the only precordial finding. Okay, fine. So once a patient presents to you with complete heart block, you're suspecting this patient is having CHB. So what's the first line investigation you'd like to consider? Like maybe you're dealing this patient in the emergency department. So
ma'am, cardiac enzymes. Cardiac enzymes.
Enzyme.
Serology.
Before that, initial investigation.
Ma'am, 2D echo. ECG.
ECG,
2D.
exactly. No, ECG, you have to be a bit more, like you cannot randomly go for the echocardiogram, because this will require a cardiologist to do this, okay? And not everybody can do echocardiograph. You have to have some sort of exposure, as well as you have to have that kind of like experience to go for the echocardiography. But ECG can be done within second, and the diagnosis can be very impromptu. Okay, so that's why this is the PACES. Oh, sorry, this is the RCP protocol. Like if they're telling you like what's the next best thing you can do, what's the initial investigation, these are the questions. So if you're thinking this is a case of cardiac arrhythmia, what's the best thing you can do? You can just go for an ECG. That's very apparent. If you are not able to pick up the ECG finding, what's the next best thing you can do? Can anybody tell me?
Echo.
If it's solely cardiac arrhythmia,
2D echo.
okay. Echo is mainly to look for if there is any structural pathology going on, okay? So we go for the 2D or the M mode, or there are different types of echocardiography. So there is 2D, there is M mode, there is color Doppler echocardiography. We usually try to assess the valve or the size of the atria and the ventricle. We try to assess the flow of the blood within this heart, and the velocity and the circumference of different valves. We try to see if there is any vegetation, any thrombus, like any structural causes can be picked up from the echocardiograph. And for arrhythmia purpose, if you're not able to get or pick up in the ECG, then the next
Maybe
best thing to do is
angiography.
no,
Coronary
angiography
angiography.
is very invasive. It's very, in the late part, you would consider Holter monitoring. Holter monitoring is something that you do, okay? So I will actually discuss about different types of cardiac investigation in my second class. I'm just trying to like give you a general idea, like so that you don't really, so that whenever we are going through the different topics, it becomes a bit easier to you to pick up. For example, ECG, very good initial screening purpose for any cardiological condition, okay? Chest X-ray.
Ma'am, sorry to interrupt.
Yes.
Sorry to interrupt, ma'am. But what is Holter monitoring? Because I haven't heard anything like this term ever before.
Sorry?
What is Holter monitoring? I have never heard about this term before.
Okay, Holter monitoring. Okay, all right, no problem. So Holter monitoring, it's basically monitoring your electrical activity of your heart for a long period of time. Like ECG, you can capture the electrical activity that's been going on in your heart, but it's done on that time, okay? So there is no monitoring of your electrical activity.
Is it
So
like a stress test that we treadmill test that we conduct?
No, it's not like a stress test. Actually, a type of device is fitted to your body by a technician, and then your electrical activity will be observed for a long period of time. It can be done in 3 time frames. Sometimes some cardiologists just can do it for 12 hours. Sometimes they go for the 24-hour, and sometimes they can go for the 48-hour monitoring, okay? So this is, in our country, the widely popular are actually two ways. One is the 24-hour Holter monitoring, and the other one is the 48-hour Holter monitoring, okay? So actually a device is fitted to your body, and then your electrical activity. Okay, it's very noisy, like, okay, all right. So your electrical activity will be monitored by a certain type of device, which is known as the Holter monitoring, okay? I hope that was clear to you.
Yes,
So,
ma'am.
all right, so just in summary, if we are thinking of what are the investigations from cardiological side, okay? In respiratory, we know that the chest X-ray should be the first line investigation. And in cardiology perspective, the ECG is the first one, okay? Chest X-ray kind of works like an adjunct. And then there is echocardiography. I've already mentioned, like this actually is best to detect if there is any structural abnormality going on. Holter is if you don't get any diagnosis from the ECG, then go for the 24-hour or the 48-hour Holter monitoring. And then there are some other, like coronary angiogram is done very routinely in our country. But in the UK, if it's not for therapeutic purpose, they usually do not want to go for the coronary angiography, okay? That's their last reserve. Like if you want to diagnose something, do all the functional tests first and then go for the like invasive procedure. So for example, there are plenty of functional tests. For example, you can go for the stress echocardiography. Like they will give you like a dobutamine or a dopamine to, you know, like make your heart muscle more excitable. And that's when they will be able to pick up if there is any regional wall motion abnormality going on or not. And then there is Stress echo is basically DSC or the WTM stress echocardiography. And then if you're like, for example, if you have a fracture in your femur, or if you're not able to do the ETT, which is known as the exercise tolerance test, then you can also go for the functional imaging as well, like WTM stress echocardiography. And then there is also radionuclide scanning, which is known as the myocardial perfusion scan. Myocardial perfusion scan. So myocardial perfusion scan are actually a bit more delicate than the WTM stress echocardiography. If for some reason they're thinking that you have more chances of having the heart attack in the next 24-hour window period, then stressing your heart through the dobutamine or the dopamine is not that advisable to do so, okay? So if you're on the higher risk of developing another recurrent attack or heart attack, then they will usually go for the myocardial perfusion scan. So they will just give some radionuclide injectable to your heart, and they will that will flow through your heart vessels, and they will be able to like take some images from the outside and detect where exactly is the abnormality going on. So I will discuss in details about these things in the next class. Just for the, now let's go back to the complete heart block. So in order to pick up the complete heart block, the first investigation is the ECG. Don't forget that, okay? There should not be any confusion regarding that. All right, so treatment for complete heart block. If one word, can anybody tell me one word? Treatment for pacing, okay? So pacemaker, yes, very good. Pacemaker is the treatment option, and we usually go for the dual chamber pacemaker. Dual chamber, all right. So our next topic here. Okay, so here is a diagram for left bundle branch block. I think if you just remember this, I think they gave like a equation here, William Marrow. So for the LVB, the W is first and the M is the last. So you can see like here, this is the W pattern in the V1 lead, okay? So that's the W pattern. This is a small W and this one's the bigger one. So if you just imagine like this is a W. And this is the M pattern here, RSR pattern in the V6, then that indicates in a very simpler way, this indicates left bundle branch block. And if it's the other way around, like in V1 or V2, you're getting the M pattern, and in the V5 or V6, you're getting the W pattern, then that is right bundle branch block. So in order to get rid of any confusion, just remember William Marrow, LVBB, okay? Forget the other one. If you try to remember both, you'll be more confused, okay? So try to, like just focus on one thing. So causes of left bundle branch block, almost anything, but it's never physiological. So remember, if there is any option regarding, so this physiological finding is common in the ECG, blah, 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 and you see the word LVB, it's directly a false, okay? So left bundle branch block is never, never, ever physiological. All right. So ST elevation, okay, I think we have already gone through this back in our undergrad level. Just remember that apart from the myocardial infarction, maybe a patient who has sustained an ischemic heart disease, like an acute ST elevated MI, and you have resuscitated the patient, and despite doing so, you're getting persistently elevated ST elevation and the patient is going like having some cardiogenic shock, do think of, have a very broad suspicion of there might be some complication like left ventricular aneurysm. Very, very difficult to control this, and it can be life-threatening, okay? So left ventricular aneurysm, and remember so I think difference between the pericarditis or the pericardial effusion and the ischemic heart disease elevation is known to everybody. I'll just try to draw. So for example, this is the P wave, Q wave, and so you see the convexity upwards, this is usually indicative of MI, okay? But for the pericarditis, this will be actually saddle shape or the concavity upwards. So for the, if this is a pericarditic pathology, so it will be concave upwards. If it's a myocardial, this is convex upwards. And you don't have to remember the normal variant, not needed. I've already discussed persistently ST elevation after MI, very high suspicion of left ventricular aneurysm. And Prince metal angina, okay, fine. And some non-cardiological condition like subarachnoid hemorrhage and hyperkalemia. Okay, you can remember. And I think another one you should remember is a bit rare, but Takotsubo cardiomyopathy can also cause ST elevation. A bit rare, but sometimes rare things do come in MRCP. So actually there is a question, I think, in the past test as well as the past medicine regarding the Takotsubo cardiomyopathy, which is why I've tried to incorporate this in here. Okay. So far, does any one of you have any question for me? All right, so ST depression, common cause is non-ST elevated MI, okay? And the other one would be digoxin toxicity and hypokalemia. So far hypokalemia, what are the ECG changes we have discussed? If one change I'm expecting in hypokalemia from the ECG, what would it be? Okay, yes, very good. Flat T wave, yes, very good. Any other?
Prolonged PR interval.
Prolonged PR interval, okay. Any abnormal wave you would be expecting? U wave, exactly. We are always very sure about the U wave. We never miss that. But then again, yes, you should remember this. So far we have discussed about the features of hypokalemia. Hypokalemia, what it can do, like imagine this is a normal ECG, all right? So it can cause flattening of the T wave, okay? Flattening of the T wave and the appearance of a U wave. Right after T, there is U wave. And then QRS complex can be broad, okay? Actually, QRS complex can be broad in both hypo and hyperkalemia. And then prolongation of the PR intervals. So this is P and this prolongation of the PR interval more than 0.2 second. So, and the other one would be ST depression. So maybe like this, it will go like this, okay? So ST depression, flattening of the T wave, appearance of the U wave, it actually happens a bit later on. QRS complex broadening, and then prolongation of the PR interval, and then ST depression. And another change you can expect in hypokalemia. Can anybody tell me? Prolongation of the QT interval as well. Or do you agree with me? Prolongation of QT interval. What are the electrical abnormalities that are responsible for prolongation of the QT interval? Very, very, very important. Hypocalcemia. Actually, RCP will maybe change hypocalcemia to hypercalcemia, and that's how you will be losing mark, okay? So just remember, most of the time, it's usually the hypos that are causing the prolongation of the QT interval, long QT syndrome. Okay, all right. So far we are good with the hypokalemic ECG changes, right? Okay. All right, Dr. Forkan, so can you tell me what are the changes so far we have discussed regarding the hypokalemia?
Flattening of the T wave.
Yes, very good.
Prolongation of the QT interval.
Okay, yes.
Widening of the QRS complex.
Yes.
PR interval prolongation.
Yes, very good.
And U wave.
Yes, very good. Another one?
Another one, ST depression.
ST depression, very good. Thank you so much for paying attention to my class. Okay, and can you enlighten us about the changes of ECG changes in hyperkalemia? Maybe just one change.
Stop it T wave.
Okay, yes. Anyone else would like to add anything to that?
Left axis deviation.
Left axis deviation, okay, a bit rare, but yes, it can happen. Anything else? Was the last one? Sine wave, exactly. So, and I've already mentioned that broadening of the QRS complex can happen in both hypo and hyperkalemia. All right. For some reason, this isn't working. Why? All right. Just give me a minute. Sorry about this. All right, so this one is also important. What are the ECG finding in hypothermia? So in hypothermia, our body temperature is going down. So all the low things will be present here. Okay, আচ্ছা একটু দেখেন তো এটা কাজ করছে না এটা কারণে মাউসটা। So bradycardia and appearance of J wave. How does a J wave look like? So if this P, this is Q, this is QR, and this is the J wave, okay? So this is just a small notch right in the QRS complex. And a prolongation of the PR interval or the first degree heart block and long QT, another hypo condition that can cause long QT syndrome, and any atrial or ventricular arrhythmia. So important one is to remember first degree heart block, they might change it to actually something else. And long QT, they can just say that, no, actually with QT, they're not going to be doing something else. Just remember the first degree heart block. Okay, all right, thank you. All right. I actually have prepared some questions for you guys. So I will be asking some questions towards our end of our discussion because our discussion topic is very much less today. So that's why I will be trying to focus on the question answer session a bit more so that I actually have heard that a lot of you guys are having some difficulty with the blocks, okay, or maybe the mock exam after the system. After finishing the system, which is why I've decided to, like go back to my previous way, like we're going to be discussing about the question answer sections more, so you don't face too much difficulty. All right, so clinical parameters, pulses. So pulse, just remember what are the different types of pulses variation and what are the conditions that are associated with this. For example, pulses paradoxes, that automatically makes you think like there is some paradoxical change, something that should not have happened is taking place. So that means if you inflate a blood pressure or BP cuff in the arm and then and the systolic blood pressure, if you rise it, maybe with inspiration, it should have dropped. With the if you take a deep breath in, the systolic, after cuffing the blood pressure cuff in your arm, your pulse should have been a bit more on the, this is actually not a variation of pulse, actually this is the variation of blood pressure. Pulses paradoxes, this is actually a misnomer. You're looking at the blood pressure, not at the pulse. So at the height of inspiration, if the blood pressure difference or the systolic blood pressure difference is more than 10 millimeter, this is known as the pulses paradoxes. And it's actually very critical. The entire mechanism is very critical. I never try to focus much on this. Just remember the conditions that can be associated with this are severe asthma and cardiac tamponade, okay? All right, so slow rising pulse in aortic stenosis, actually any stenotic valvular pathology can cause slow rising pulse, but more in aortic stenosis. Even mitral stenosis can also cause slow rising low volume pulse. And collapsing pulse, remember in hyperdynamic circulation or whenever there is volume overload, so it will cause collapsing pulse. Also, it has another name. Can anybody tell me what is it known as?
Water hammer pulse.
Water hammer pulse, exactly. So does anybody have any idea how do we assess the water hammer pulse by the bedside?
By with JVP.
Okay. There's actually an easier way of checking the water hammer pulse. Okay, Dr. Neha, can you mute? Okay, thank you. All right, so actually what you have to do is first you have to put your hand in the patient's hand like this, then feel for the pulse, and when then start moving your hand very slowly and try to assess where exactly the pulse is the lowest felt, okay? So of course, against the radial bone, it will be felt more prominent way, but move your hand a bit slowly where you can no longer feel the pulse and then press on it, and then ask the patient whether she or he has any pain in the shoulder. And then with permission, just, lift up the arm like that. And if you see that after an absence, a blood volume is going or hitting you in your fingertip, that means that there is presence of collapsing pulse, okay? So this is very important in diagnosing aortic regurgitation, because any diastolic murmur, I think, is very hard to pick by the bedside. So there are some peripheral signs that can give you some clues, and this is one of the clues. The collapsing pulse is a very, very good clue for picking up aortic regurgitation. All right, so apart from the aortic regurgitation, you can expect this to be present in the patent ductus arteriosus and any hyperkinetic or hyperdynamic circulation like anemia, thyrotoxicosis, fever, exercise, pregnancy, etc. Pulses alternance, that means with every beat of the heart, the volume of the pulse will vary from one beat to another. So when does it take place? It takes place in severe left ventricular failure, and pulses alternance is seen also in pericardial effusion as well. But for MRCP purpose, I would just focus you on the, rather focus on the left ventricular failure. Bispherians pulse, just remember mixed aortic valvopathy like aortic stenosis with aortic regurgitation will cause this. So one, a low volume pulse followed by a high volume pulse. So this is known as the Bispherians pulse. And the jerky pulse, it's only one diagnosis is for that is hypertrophic obstructive cardiomyopathy. So actually it occurs because the atria is contracted against a very stiff ventricle in hypertrophic obstructive cardiomyopathy, thereby the pulse will be very much jerky, like it will feel like how do I say, like a pendulum hitting the wall or something like that. So it's not that fast, it's not tachycardia, it's a bit different. So imagine a very high volume pulse occurring very fast. So that's a jerky pulse. Okay, so heart sound, okay, this is important, but the pathological variation and the causes behind the pathological variations are important. We already know that the first heart sound is produced by the closure of the mitral and the tricuspid valve, or the AV valves, and the second heart sound is produced due to aortic and the pulmonary valve closure. So the first heart sound, if this is loud first heart sound, it signifies that there is mitral stenosis. And if first heart sound is soft, what does it signify? Opposite one, mitral regurgitation, okay? So in the second heart sound, there are too many pathologies that might be going on. For example, the second heart sound, if it is loud, then consider if this is due to pulmonary hypertension or systemic hypertension. Usually in systemic hypertension, second heart sound loud, it's very rare to find, but rather than pulmonary hypertension, the loud P2, what we examine in the precordium, that is a common finding. And if it becomes soft, think of if there is any aortic valve pathology, and the fixed wide splitting occurs in atrial septal defect. And there is also some condition that causes reverse splitting of the second heart sound. So one very, very important cause for the reverse splitting is severe aortic stenosis, and the other one is the left bundle branch block, okay? And third heart sound always indicates gallop rhythm or heart failure. And fourth heart sound is, a lot of people say that S3 and S4 can be sometimes physiological, but I never agree with that. It usually indicates pathology, some sort of pathology. Like S3 always indicates there is some sort of heart failure. And S4, it usually indicates like there is some sort of like high pressure abnormality in the heart going on. So like, for example, in case of uncontrolled hypertension, in aortic stenosis or hypertrophic obstructive cardiomyopathy, all of these are causing pressure, like pressure overload within the heart, thereby causing an additional sound, which is known as the fourth heart sound. Okay, so I think this picture is just for examination purpose. If you just think of yourself as the patient, you start with the mitral area, which is in the left fifth intercostal space along the mid-clavicular line. And then there is the tricuspid area, which is along the left lower sternal edge in the third to fourth intercostal space. And right on top of it, in the second intercostal space on the left side, there is pulmonary area. And on the right side, in the same space along with the pulmonary area, but on the right side is the aortic area. So what murmurs do you expect? In the mitral area, it's either mitral stenosis or mitral regurgitation. So the mitral stenosis murmur is the diastolic murmur, and the mitral regurgitation is the systolic murmur. And remember that systolic murmurs, they have radiation, okay? So the mitral regurgitation, the systolic murmur will be radiating to the axilla, and in case of aortic stenosis, the systolic murmur will be radiating towards the carotid. This is very much undergrad level talk. I'm not going into details about this, and this is actually more needed for the PACES examination, not for the part 1. Okay, heart sound. Okay, here they have, I think this diagram you can probably go through once. It's quite good that they try to summarize every second heart sound pathology in one passage. It's very, I think it's very handy. So go through this just once, okay? And here you can see the causes for a reverse or paradoxical splitting of the second heart sound. All right, so the basic mechanism for A2 and P2. So we already know that there are 2 components for the second heart sound. One is the aortic component, and the other one is the pulmonary component. And when we take inspiration, then the P2 or the pulmonary valve will be closed in a bit latter part, okay? So it's a very physiological finding. If you tell maybe a Linthin patient, if you tell them to take a deep breath in, and if you look for the second heart sound in the pulmonary area, you can get an, splitting of the second heart sound. You can hear this. It's a normal physiological phenomenon. But once it becomes fixed, it usually indicates pathology. So that's the main thing. Just try to go through once or twice, not that important, but the causes can come up in the part 1 examination. And the most common one is the LBBB and the severe aortic stenosis, like the paradoxical splitting. All right. So differential diagnosis for murmurs, I think once you go through the different valvular pathology, it will be easier to come back to this. Like in ejection systolic murmur, the differentials are usually aortic stenosis, pulmonary stenosis, and the atrial septal defect. And right now it will seem like a lot of cramming at the moment. So I would suggest that go through the valvopathy first, and then come back to this passage. Then it will be a bit easier to grasp onto. JVP, okay. Actually, I cannot say that JVP is not important for part 1, because sometimes they can give you some theoretical question, like which wave signify what. So it can come up in the part 1 examination. So JVP, it almost always indicates the right atrial pressure. And I think when we try to examine a JVP by the bedside, we tell the patient to lie down at 45-degree angle. Then we expose the patient properly, and first of all we try to look at it without feeling for it. Okay, so if you shine the light from the back of the neck, then you'll see there is raised JVP, and this is like a waveform, like a pulsatile form. So if it arises from in between the 2 heads of the sternocleidomastoid muscle, and from the sternal head, from here, this is the sternal head of the clavicle bone. So you have to measure the height of the JVP from this particular point. Okay, so and another important thing, if this is fixed JVP, that only indicates superior vena cava obstruction. Okay. So superior vena cava obstruction patient, apart from the raised JVP, they have some other features as well. Like they can have plethoric face, and they can have some shortness of breath or difficulty in swallowing. And this occurs because of the lung cancer, maybe a Pancoast tumor compressing over there. Thereby, this is not the cardiology section. So non-pulsatile JVP is not the cardiology topic. So here it's quite easy to remember for the exam purpose. It's easy to remember by the acronym, if you see, we know that this is a double peak pulse, okay? But the carotid pulse is single peak, and JVP is the double peak pulse, and it's best seen rather than palpable. There is some basic difference between the carotid pulse and the raised JVP. So this is the A wave, this is C, and this is V. Okay, this is the X descent, and this is the Y descent. So here the A wave, remember, it signifies atrial contraction, okay? And the C wave here, sorry, I'll just go through. C wave indicates closure of the tricuspid valve, closure of the tricuspid valve. So C matches with C here, okay? And then V is passive filling, okay? Okay, this is getting difficult. All right. So this is the right atrium, this is the right ventricle. And okay, so maybe this is the internal jugular vein, or this is actually the superior vena cava, okay? And superior vena cava has different tributaries, and maybe here, this is the internal jugular vein. All right, so if in the right atrial pressure, there is buildup of the right atrial pressure will cause increase in the JVP, okay? So A wave, atrial contraction, I've said that. C wave indicates closure of the tricuspid valve. And then V wave is basically when the tricuspid valve is closed, the atrium is filling, okay? So that indicates the V wave. And there is X descent and Y descent. X descent is basically fall in the atrial pressure during the ventricular systole. So that when the ventricle contracts, the pressure will somewhat be relieved in the right atrium, right? So that is denoted by the X descent. And the Y descent is basically when the valve finally opens, when the tricuspid valve finally opens, the blood will be entirely drained out. So that's the last part for the pressure release of the right atrium, okay? So the X descent, all of this, the JVP will be, this is the downslope. X descent is the initial portion and the Y descent is the lateral portion. Okay, like this. So that means the tricuspid valve is still closed in the X descent. But there is beginning of the ventricular contraction, and thereby there is somewhat of a pressure release within the right atrium. And when the tricuspid valves open, the final release of the pressure from the right atrium. So that is denoted by the Y descent. So pathological condition for A wave, V wave, blah, blah, blah. The important ones you have to remember for MRCP purpose is A wave, large A wave, canon A wave, and giant V wave, nothing else. Like you can see, like it signifies the atrial contraction. So whenever the atrial contraction or the force of contraction is more, when there is pressure buildup of somewhat of volume overload, then the A wave will be more prominent, okay? Like for example, tricuspid stenosis, the valve is stenotic, so the blood volume or the column will not be able to pass from the right atrium to the right ventricle. So there is pressure and the volume buildup, right? So in tricuspid stenosis or even tricuspid regurgitation, of course, JVP will be raised. So pulmonary stenosis, again, same pathology, pulmonary hypertension, buildup of pressure within the right side of the heart, thereby causing pressure over the right atrium. And A wave will be entirely absent in atrial fibrillation because atrial fibrillation is a supraventricular arrhythmia, right? So, so the atrium is not able to contract properly. So there will be no A wave at all. And canon A wave is when there is huge amount of atrial contraction against a closed tricuspid valve. So the canon A wave differentials are very, very important. The complete heart block, ventricular tachycardia. In complete heart block, I've already mentioned. And ventricular tachycardia or the ectopics, actually every differential here is very important. The single chamber ventricular pacing, what exactly happens here is that so imagine the pacemaker lead is placed in here, and this is a single chamber, right? So the sensing and the pacing has been done within the right ventricle. And so the atrial, what happens here is that this will actually cause a negative pressure. Okay, the re-entrance of the abnormal arrhythmia will cause pressure over the right atrium against the closed tricuspid valve, thereby causing a false increase in the pressure accumulation within the right atrium. If it's getting too complicated, forget about this. Just remember the differentials. Okay, so this is actually one of my teacher. He has a very high, he's very interested in pacemaker. So that's why I also had to like go through a bit more, like deeper understanding. But if you're having difficulty, just know like that most of the cardiac arrhythmia condition, like complete heart block, VT, or nodal rhythm, or single chamber ventricular pacing will cause this type of canon A wave. For the canon A wave, remember the different types of arrhythmia. And C wave, okay, not important. V wave, giant V wave is particularly important. This is seen in only one pathological condition, in the tricuspid regurgitation, because of the volume overload. So here I will just try to draw the A, C, V, X, Y. So what does the A wave signify? Atrial contraction. What does the C wave signify? Closure of the tricuspid valve. Okay, very good. Okay, and what does the V wave signify? Yes, tricuspid regurgitation. Very good. X descent and Y descent. So when is the tricuspid valve entirely open? Y descent, exactly. Very good. So large A wave is seen when there is some sort of pressure or volume overload within the right atrium. So tricuspid stenosis, pulmonary hypertension, blah, blah, blah. Canon A wave related to cardiac arrhythmia, like complete heart block, ventricular tachycardia, nodal rhythm, single chamber ventricular pacing. And C wave, okay, not important. Giant V wave, only one condition, tricuspid regurgitation. Okay, so that's all you need for the part one. It looks horrible. Are you guys finding cardiology a bit boring today? Because physiology, I find it a little bit boring. Oh, I hope when we are discussing about the disease, when we go to the disease section, things will be a bit more easier and more palatable. So canon A wave, I've already told you, like the irregular canon wave, only one condition, that is the complete heart block. All right, so we're actually done with the physiological portion, and now the easier section, infective endocarditis. Okay, modified Duke criteria. So you have to remember the criteria is a bit more. There are too many information here. For my easy understanding, I usually try to make things a bit more simplified. So in the Duke's criteria, there is 2 major criteria and 5 minor criteria. So 2 major criteria is positive blood culture. Positive blood culture typical of infective endocarditis organism. And the second one is echocardiograph evidence of any type of new regurgitation, maybe some vegetation, some thrombus or prosthetic bulb dehiscence or whatever. Basically, echocardiographic changes are in the major criteria. And in the 5 minor criteria, fever, more than 38 degrees centigrade, and the vascular or thrombotic phenomenon, for example, stroke, any emboli, any thromboembolism episodes, blah, blah, blah. And Janeway lesion is actually a embolic phenomenon, okay, Janeway lesion. And on the other hand, immunologic or vasculitic, this will be painful. So Osler node is a vasculitic phenomenon, like you see in the fingertip. It's quite painful. And only 3 things are within the immunologic or the vasculitic phenomenon. One is the glomerulonephritis, one is Osler node, and the other one is Roth spot. So I usually remember it like GOR, GOR. So that indicates the immunologic or the vasculitic phenomenon. So fever, thromboembolic phenomenon, vasculitic or immunologic phenomenon, and the other one is risk factor, like a person who has had IV drug abuser, immunocompromised, like has diabetes or previous history of infective endocarditis. So they are at risk of developing infective endocarditis again. And the final one, the 5th criteria, is blood culture positive, but for atypical organism. So that's just the very simplified way of remembering the Duke's criteria. And what are the findings of infective endocarditis? So of course, fever, any fever more than 2 weeks with no finding at all, do think of infective endocarditis as a differential. This is from my personal experience, as well as from what I've learned from my SARS and my teachers. If no cause, like you cannot explain the fever by urinary tract infection, by pneumonia, by COVID, by some tonsillitis, sinusitis, no infection source you cannot detect, do think of infective endocarditis, okay? So fever is an important one. Second one is patient might complain of tiredness only, fatigue or tiredness, okay, or generalized weakness. Patient might be anemic, and patient might have a background history of rheumatic heart disease plus minus, not always necessary. Patient might have some sort of prosthetic valve or some cardiac surgery before. Unlikely in CABG, of course, prosthetic valve or any valve operations before. And then any dental procedure, very, very important, any dental procedure in recent time, or dental review, bad oral hygiene, poor oral mouth hygiene, this will be indicative or some risk factor for infective endocarditis. Another feature would be like in fundoscopy, Roth spot can be present. Skin rashes. By skin rash, I mean like in the palms of your hand or in the plantar surface or the sole of the feet, there might be presence of Janeway lesion, very rare finding. And in the fingertips, some painful lesion like osseous lesion. In the nail bed, splinter hemorrhage can be present as well. And there might be some mild in the abdomen, mild splenomegaly, okay? Urine, important would be hematuria due to glomerulonephritis. And of course, with complication, patient might have features like myocardial infarction even because of the thromboembolic complication or even stroke, okay? So important, these are the important features. And of course, in the precordium, maybe new murmur, new regurgitant murmur, some changing murmur, which is known as the Carey-Coombe murmur. So these are the findings for the infective endocarditis generally together. So go through the lecture book. I think pretty much everything is written over there. I've just tried to summarize everything up in a very simplified manner. So you're suspecting this patient has infective endocarditis. How would you like to investigate this patient? Go for a complete blood count with ESR and CRP. In the presence of an active infection, these will be increased. You might expect features of anemia, features of infection, features of inflammation, right? Second one, you can go for like maybe you can do an ECG in a very easy way, okay? Third, okay, chest x-ray to exclude if there is any pneumonia or something else that there might be going on, any cardiomegaly or valve calcification, blah, blah, blah. Okay, or any features of pulmonary hypertension. And then number 4 would be, I'm not saying like this is exam purpose, like just some from basic to more elaborative type of investigation. Okay, so you can go for the urinary to see if there is any proteinuria, any hematuria. And then if a patient is diabetic, definitely check the blood sugar like RBS. If there is concomitant electrolyte abnormality, go for the basic investigation like serum urine electrolyte. Okay, and then in order to confirm, very, very important, 2 tests. One is blood culture, blood CS, and number 2 is echocardiographic evidence, okay. So if you tell me in order to diagnose, if you want me to pick in between these 2, it's very difficult. Sometimes you'll see like there are some questions stem after reading that, and they will ask you like which investigation to go for to confirm infective endocarditis. You want to give the answer like echocardiography because you want to establish this as a case of infective endocarditis by detecting if there is any regurgitation or any valvular dehiscence or some abnormality. But sometimes the answer is blood culture, okay? So I think if they have like different types of, all the 4 like options are chest x-ray, maybe an ECG, and then the other one is CBCA, and the other one is maybe urinary, and the 5th one is the blood culture. Go for the blood culture, okay? But if the options involve both blood culture and echocardiography, I would say it's safer and better to go for the blood culture, okay? Give the blood culture as the answer. It's actually very difficult and complicated. Sometimes they might have echocardiography in their calibration in the stem as well. So if you, like start practicing from the past test, you will exactly know like what struggle am I talking about. So blood culture, okay, so important organisms, and how exactly would you go for the blood culture? So I think in here they have discussed about at least 2 blood culture, but in clinical practice, we go for 3 separate blood culture, 3 separate sets of blood culture from 3 different sites. So maybe if it is taken from the left arm, then the other one would be taken from the right arm, and maybe some from the leg as well. So 3 separate blood culture and 12 hours apart, one culture from the other. And then if the patient is already taking antibiotic, go for the FAN method and try to send this sample into 3 different lab investigations, okay? Like different facilities, so that you do not miss any single chance of detecting typical organism, okay? So that's the way for doing the blood test. And echo I've already mentioned. All right, so what are the typical organism for infective endocarditis? Another hot topic for RCP. So previously it was known as the Streptococcus viridans. It has further 2 different types of pathogen. One is the Streptococcus mitis, and the other one is the sanguinis or something like that. Sounds like an Italian name. So Streptococcus viridans was thought to be the most common cause for infective endocarditis, but nowadays it's been estimated that Staph aureus is, okay, especially if there is acute presentation, first of all, and if there is risk factor like IV drug abuser, if the person is having some immunocompromised condition like diabetes mellitus, do think of Staph aureus, okay? Number 3 is Staph epidermidis. Staph epidermidis is involves the prosthetic valve. And within 2 months of the operation, okay? So the early onset infective endocarditis with the background of prosthetic valve within 2 months period, then do consider this might be a case of Staph epidermidis, okay? And if it is more than 2 months, this will be just like the native valve, okay? So that will be a Staph aureus. All right, and the 4th one is if there is some sort of underlying colon malignancy, then Streptococcus bovis is the organism, okay? So I think in the lecture, this has been like given, this information has been given over and over again. But as it's very important, so do think of, do go through this topic several times. All right, I've talked about this. And there are some non-infective causes like SLE, malignancy, and merantic endocarditis. Culture negative, a bit less common, but then again, also considered as typical organism for infective endocarditis are Coxiella burnetii, Bartonella, Brucella, and the Hassett group. So this is Aikenella, Kinganella, Cardiobacterium, and the Actinobacillus and the Haemophilus group, okay? So, but then again, these are very atypical organisms. So sometimes they can be culture negative or hard to detect. And if the patient is obviously on prior antibiotic. And here, I think there is one question here. So risk factor from highest to lowest. If there is a previous episode of infective endocarditis, that is known as the single most important risk factor. Previous history of infective endocarditis. Not prosthetic valve, not rheumatic valve disease, not IV drug abuser. Previous history of infective endocarditis is the most dangerous and most common risk factor. Okay, so here you can see there are some poor prognostic factors, like with Staph aureus infection, if there is prosthetic valve, very high mortality. Like imagine this person has spent tons of money to go through this valve replacement procedure. And then the worst outcome you can consider is like even a person's valve fails if the patient is having some heart failure, maybe, like recurrence of the primary disease, that's not even that kind of severe. But if a prosthetic valve patient develops infective endocarditis, chances are the mortality rate becomes very high within the next 2 to 3 years, okay? And the only way to treat this is, again, go for the valve replacement. All right, and culture negative endocarditis, of course, and low complement level, these are the poor prognostic factors. Mortality, of course, among all the other organisms, Staphylococcus holds the highest mortality. So treatment, I think it's a bit complicated, and the different scenarios will require you to answer a bit differently. But if the stem tells you like the patient has never had any previous episode of infective endocarditis, just the first time he's diagnosed with this, then try to give your answer like intravenous benzyl penicillin, okay? Because in some sort of way, you're assuming that this patient the patient is sensitive to penicillin. Like it will be within this box. Endocarditis caused by fully sensitive streptococci, okay? And if you see like there is some sort of penicillin allergy or something like that, then you cannot give answer to penicillin type of group, like not penicillin, not amoxicillin, not flucloxacillin, not ceftriaxone. It's either vancomycin plus minus other combination, all right? And if you're seeing like this is a case of prosthetic valve, and important thing to pick up here is that rifampicin will be there, okay? Yeah, I think that would be my advice towards you. So start off with, if this is the first case, go for IV benzyl penicillin. If this is the prosthetic valve, try to look for the word rifampicin. If this is a penicillin allergy case, do not go for any penicillin type of group. Go for vancomycin or something like that. And gentamicin will be plus minus. It will be easier to pick up. Most of the infective endocarditis patients are given gentamicin, no matter how much you tell me, like I can just treat infective endocarditis with IV benzyl penicillin, almost always you have to prescribe gentamicin. Okay, from a practical point of view. And what are the indications for surgery? This is important. Patient is still symptomatic or refractory to the maximal dose of antibiotic if there is presence of fungal infection, if there is mechanical obstruction or very large vegetation, and if there is severe valvular incompetence like severe regurgitant murmur and aortic abscess, which is indicated by the prolongation of the Pierre interval. This line is very important. And of course, acute heart failure is another indication for surgery. Okay. Here, this word recurrent emboli, okay, this is important. They might give you options like which factor from the given option is the indication for surgery in an infective endocarditis. So they might give you like emboli on right or left kidney, and you're feeling like, okay, this might be my answer. But remember, the word is recurrent emboli, not the first episode of emboli. If the patient is having some first or second episode of emboli, there is still time to give the patient antibiotic. Okay, prophylaxis. Okay, the short answer to this entire paragraph is no prophylaxis is needed anymore. Okay, be it some dental procedure, be it some colonoscopy, endoscopy, or some urological procedure, maybe like in pregnant women, consideration of cesarean section. No endocarditis prophylaxis is given, even if the person has rheumatic heart disease. But yes, if the patient has already had infective endocarditis previously, then that person will belong to the high risk group, and that person will be given antibiotic, okay? So that's the gist for this entire paragraph. Okay, valvular pathology.
Ma'am, can we get a break for 5 minutes?
Do you guys, okay? I mean, sure, yeah, we can take a 5-minute break, it's fine.
Thank you.
Okay. Okay, we'll actually try to like cover the topics for discussion today. So rest of the topics are not that difficult. Actually, we'll start with the aortic stenosis. So aortic stenosis is one of the commonest cause of valvular pathology. And this is more commonly seen in elderly population because of the degeneration or calcification. Another cause, if the patient is less than 65 years of age, do think of if there is any congenital abnormality, like bicuspid aortic valve is an important cause for aortic stenosis, okay? So in the precordium, you can expect there is an ejection systolic murmur radiating to the carotid. That's an important finding. And what are the markers of severity or bedside clinical markers of severity? This is an MRCP part 1 question. Like if you start off with pulse, in the pulse, if there is low volume and slowly rising pulse, that means there is severe aortic stenosis. If the blood pressure, after the pulse, the blood pressure, if the blood pressure is narrow pulse pressure, that indicates severity, okay? Then in the chest, like in palpation part, if the apex beat is shifted and this is forceful or heaving in nature, then that indicates this is a severe aortic stenosis. And if you can get some thrill in the aortic area, so thrill basically means there is severe aortic stenosis. And now you're ausculting, okay? Now in the auscultation, if you find that the second heart sound, particularly the aortic component of the second heart sound becomes soft, or if there is reverse splitting of the second heart sound, then that indicates there is severe aortic stenosis. And there is a lot of debate regarding if the murmur is harsh. A lot of people likes to say that this is a severe aortic stenosis, but actually it's a wrong conception. Systolic murmur can generally be harsh, okay? So you should not worry about the harsher quality for detecting whether this is a severe AS or not. Rather, if it's a diastolic murmur, and if it's happening for a longer duration of time, that usually indicates this is a case of severe murmur, okay? Like in case of aortic regurgitation, if the diastolic murmur is happening for a long period of time, that indicates this is a case of severe aortic regurgitation. So, okay, and presence of fourth heart sound. That also indicates that this is a case of severe aortic stenosis. All right, so this will be easily confirmed by doing an echocardiograph, echo, especially the Doppler. We will try to look at the valve circumference area and the pressure gradient, like the peak pressure gradient, this is known as. So, and the most clinically, you can just tell whether a patient is having severe aortic stenosis or not by developing symptom. There are 3 symptoms. One is syncope. Number 2 is exertional dyspnea or shortness of breath. And number 3 is exertional chest pain. So if a patient develops any one of these symptoms, that means this is a case of severe aortic stenosis. And the one way to deal with this is valve replacement. So you might have like questions like indication of valve replacement. So number 1 is definitely sign symptom. Number 2 is if there is coexisting coronary artery disease. Number 3 is patient is asymptomatic. However, the peak pressure gradient is more than 50 millimeter mercury. And patient has severe left ventricular systolic dysfunction. Then you can go for the surgery, okay? There are other indications of surgery in aortic stenosis, but these are the simplified indications. All right, treatment, of course, either surgical correction, and like surgical correction is aortic valve replacement. And the other one is, can anybody tell me? For an aged person, if the patient is too frail to go for this, which one? Valvoplasty or TAVI operation. TAVI is known as the transcatheter aortic valve implantation. This kind of looks like a box or a purse ring type of thing. Okay, it looks like a bag. So this is actually placed through the catheter, like in the angiogram, it is placed through the catheter in the aortic valve, okay? And then that helps to keep the valve like patent. So if a person, like for example, a person more than 75 years of age has other comorbidities and too frail to undergo this type of valve replacement, which is an extensive operation, so TAVI procedure is done. And in asymptomatic patient, we can just follow up the patient regularly with annual echocardiographic follow-up, and we can consider some afterload reducing agents such as ACE inhibitors or ARB. If the patient is asymptomatic, no sign symptom, then echo follow-up, and if one drug, then that is ACE inhibitor. All right, the next one, aortic regurgitation. So aortic regurgitation, what type of murmur? This causes early diastolic murmur, okay? In which area? It is known as the neo-aortic area. So what does a neo-aortic area mean? Like we tell the patient to sit up and then, just bend forward a bit. And then we tell the patient to take a deep breath in and then take a deep breath out and then hold the breath in. And we put the stethoscope in the left third to fourth intercostal space along the parasternal region, okay? And then we will be able to detect aortic regurgitation murmur. If anybody of you have ever heard aortic regurgitation murmur, it's very distinct. It sounds like somebody has pushed a drum, okay? And then the big drum has hit the floor. It kind of sounds like either a drum has fallen to the floor or some like shooting, like pistol shooting from a very distant site. So you just have to like have a clinical ear to detect this type of murmur. And aortic regurgitation, it causes volume overload. So you can expect volume overload features, all right? So the pulse will be, we have already discussed like collapsing or water hammer type of pulse. And the blood pressure, there will be wide pulse pressure. And if this is more than 100 millimeter mercury, then there is definite indication of surgery, all right? And let's see, I've already discussed about the precordial finding, and aortic regurgitation, they do have some peripheral sign. So like, for example, there might be some associated head nodding and the D Muset sign and then Corrigan pulse, blah, blah, blah. Not that important for the part 1 examination. There is one sign that we see, the capillary pulsation, which is known as the Quincke sign. And there is also the like Duroger's murmur, something like that, in the pistol shoot murmur in the femoral pulse. These are just, like some Fruit Loopy name, not important for the exam. All right, so any valve pathology, think of 4 investigation. One is the ECG. If there is any cardiac arrhythmia or any hypertrophy or any exudation, it will be picked up by the ECG. And then there is chest X-ray PFU to see if there is any cardiomegaly, some valve calcification, or any features of pulmonary hypertension. And then in order to confirm, go for the echocardiography. This will show the flow, the size, and the other chamber variation, chamber size and function. And finally, cardiac catheterization. This is important. To see if there is any concomitant coronary artery disease, as well as to pick up if there is any pulmonary hypertension or the pressure gradient, okay? So cardiac catheterization, this is actually left heart catheterization or right heart catheterization. Right heart catheterization is done to pick up if there is any pulmonary hypertension. Left heart cardiac catheterization is done to see if there is any coronary artery disease. Just let me know if I'm going too fast. Actually, I'm trying to like cover the points, that's why. But if you want me to, say it again, I'm more than happy to do so. So now we will discuss about the mitral pathology, mitral valve abnormality. So 2 basic ones are mitral stenosis and mitral regurgitation. So the mitral stenosis causes mid-diastolic murmur, and the mitral regurgitation causes pansystolic regurgitate murmur. So regurgitant murmur is pansystolic, occurs in the systole, or this is also known as the hollow systolic. So through the entire phase of the systole, you can hear the murmur. And the mid-diastolic is very distinctive. We all read about this, like low-pitched, localized, rough, rumbling character in mitral stenosis. So the normal circumference of the mitral valve is 4 to 6 centimeters square. If this is less than 1 centimeter square, this is known as the severe mitral stenosis. So there are certain complications of mitral stenosis. Like if I draw a diagram like this valve is becoming stenotic, okay? Not a lot of blood will be able to pass from the left atrium to the left ventricle. So there will be a backward pressure buildup. So from the left atrium, the pressure will build up to the right atrium. And then in the right ventricle, the pressure is building up. And we know that from the right ventricle, the pulmonary trunk arises, right? So the pulmonary hypertension develops. And then the pulmonary, in the lung, we know that 4 pulmonary veins are opened into the left atrium. So this will put added pressure again on the left atrium. So this is like a vicious cycle. Like the backward pressure is causing more and more pressure, right? So you can expect over a long-term period, the left atrium can be enlarged, all right? So that's why it can actually, the left atrium, behind the left atrium, there are 2 important structures. One is the esophagus, and the other one is the left recurrent laryngeal nerve, okay? So it can put pressure on the esophagus, causing dysphagia, and it can put pressure on the left recurrent laryngeal nerve, causing hoarseness of the voice. So this is known as the Ortner syndrome. Okay, and of course, with so much pulmonary hypertension and plethora going on, so there is more chance of recurrent chest infection. There is increased risk of hemoptysis. With mitral stenosis, there is increased risk of congestive cardiac failure. Although left ventricular failure is very less likely to happen in mitral stenosis, okay? Are you following what I'm trying to say? Right heart failure, okay, sure. So right heart failure is more common than left heart failure in case of mitral stenosis. All right, I think, yes. What are the indications of surgery? So we know like the surgery can be done in 2 ways. One is the less invasive way and a bit more invasive way. So more invasive way, that definitely means valve replacement, okay? And in less invasive way, there are different procedures like OMC, or the open mitral commissurotomy. There is CMC, which is known as the closed mitral commissurotomy. And there is PTMC. PTMC and CMC is basically the same thing. This is like the part transcatheter mitral commissurotomy. So the indications are more or less same, but if in a mitral valve, there is concomitant mitral regurgitation, if there is left atrial thrombus, if there is extensive calcification, and the valves are not pliable, then you cannot go for this type of less invasive procedure. So in that case, you have to go for the valve replacement. Just remember this, okay? So if there is like a concomitant regurgitant murmur, if there is a atrial thrombus, left atrial thrombus, and if there is severe calcification of the mitral valve and the valve clasp, like the mitral leaflets, are not moving properly, so that way you should not go for the valvoplasty or the valve repair operation, rather than go for the replacement operation, okay? All right, let's see. Where did the, no, I don't think so, that's one. Okay, I had this saved right here. Where did it go? Ah, there you go. We have covered the aortic stenosis. Okay, regarding the angiodysplasia and aortic stenosis. So in elderly patient, if you're getting like fresh parectal bleeding, and if you go for a colonoscopy and you see that there is arteriovenous malformation or some angiodysplastic change, and in the examination, you find that there is an aortic stenotic murmur. So this has a very fruit loopy name. This is known as the Hades syndrome, okay? So there are several questions that can come, like in aortic stenosis, the patient is presented with some fresh parectal bleeding. What do you think the condition is? So they might either require for you to diagnose this, or they might tell you to, pick up a form of investigation tool. Like, for example, colonoscopy is the investigation of choice, but in the setting of acute bleeding, you cannot go for colonoscopy because it will actually cause more bleeding risk, okay? So you go for the mesenteric angiography rather. All right, aortic regurgitation, we have discussed about this. Marfan, okay, I'm getting to it. just a bit. MS discussed. Rheumatic fever. Symptoms and severity. Okay, we're almost towards the end, no worries. All right, so Marfan syndrome, actually, Marfan syndrome is a cause for a lot of valve pathologies. So what does it mean? It's, first of all, it's a genetic condition and it's a connective tissue disorder. So because of the fibrillin 1 gene mutation, this can lead to some abnormal skeletal deformity. So for example, a Marfanoid habitus, like tall stature is the pathognomic sign, and the arm span ratio will be more than the entire height ratio. So we ask the patient to stand up in a corner, and then we tell the patient to, spread their arms like this, and we measure this arm to arm distance, and then we measure the height, and this arm to arm distance will be more than 1.05. Okay, so that's one thing. And if you look at the face usually looks a bit long, haggard face. If you check the oral cavity, there is high arch palate. And if you look at the eyes, then you can see there is upward dislocation of the lens. And if you see like the fingers, they kind of look like spider fingers, which is known as the arachnodactyly. And there are some skeletal abnormalities, like in the chest, there might be pectus excavatum, like the sternum will be bulging outside. And then there is kyphoscoliosis on the backside. And the flat foot, also known as the pes planus, can be present. And in the heart, two important murmurs. One is the aortic regurgitation, and the other one is the mitral valve prolapse, okay? And dural ectasia presentation is usually like, this is the ballooning of the dural sac, okay? So the presentation is almost like low back pain with urinary incontinence, okay? So that's the dural ectasia presentation. All right, so Marfan syndrome, okay, we need the genetic counseling. We need to form up a multidisciplinary team involving the geneticist. We need to involve the cardiologist. And also there might be chances of recurrent pneumothorax. So we need to involve the respiratory physician as well. And with modern medicine, the life expectancy of Marfan's has actually increased over the time period. So ACE inhibitor is actually a good pharmacological option to, halter the cardiovascular mortality or the incidence. And mode of death in Marfan's is actually cardiovascular complication. Osteogenesis imperfecta, I think it's a bit difficult for the newer candidates to catch up on this, but I have actually gone through this in my last rheumatological session. So osteogenesis imperfecta, also known as the brittle bone disease, it has some association with some cardiovascular condition as well. So that's why I think they have tried to incorporate this into here, but it's no problem. You just go through this in the rheumatology section, okay? Ehlers-Danlos very much looks like the Marfan's patients, but they have a problem in their collagen fibers, okay? So that's why their skin is a bit more elastic. So if you pull their skin by their hand, this will come off like very easily. And there is increased risk of bruising, and some skeletal deformities are also happening in the Ehlers-Danlos patient. And one of the most devastating complications can happen in the Ehlers-Danlos is the subarachnoid hemorrhage, okay? Remember this one. There are some bedside tests that you can do for the Marfan patient. Has anybody seen this so far? There are basically like 3 hand tests that we can do. This is just for the clinical purpose, okay? So we can go for the this type of test. Okay, you don't have to remember the name of this test because this can be a bit more difficult to remember. Just tell the Marfan patient to touch by the wrist, touch like this. Okay, we are not able to do so, but the Marfan patients, they will be able to do so. Like touch their thumb with their little finger. And the other test, we will tell them to curl up their fingers like this. Okay. In our finger, you can see like the thumb is not showing here, but in Marfan's patient, the thumb will actually, be prominent from here, like it will show like this. Okay, so you can do these 2 tests to confirm the Marfan. And also not all the 12 patients are Marfan patients. This is a common clinical cliche we do. All right, we've gone through the mitral stenosis and rheumatic fever. Just read about this. This is a very undergrad topic. Complication, okay, I've discussed about this. Indication of intervention, Plus minus. Mitral valve prolapse. Just read the association of mitral valve prolapse, okay? So sometimes they can come up in the examination. Just most of the time it's some genetic condition, like as you can see in the Turner syndrome, the Marfan's Fragile X, osteogenesis imperfecta, pseudoxanthoma elasticum, and there is WPW, Ehlers-Danlos, long QT. So these are, just go through the association once. Prosthetic valve, okay. So valve replacement, of course, we can go for either the prosthetic valve, which comes from the natural source, either the bovine or the cow origin, or the porcine or the pig origin valve. And the mechanical valves are basically built from titanium, okay? So disadvantage and advantage. So if it's an older person, then go for the bioprosthetic valve, okay? No, and the life expectancy, you're thinking that the patient's life expectancy is less than the valve life expectancy. In that case, go for the bioprosthetic valve, okay? But for example, in younger patient, they're supposed to live for a longer period of time. So try to focus on the durability of the valve. Of course, a valve that is made up of titanium or steel, imagine like a steel-made thing will last longer, okay? And something that's made from the biosynthetic source, it will not last longer. As well as if it's from a biosynthetic source, you don't really need to go for coagulation, anticoagulation for a long period of time, just in the first 3 months. And if it's a mechanical valve, you need to go for the lifelong anticoagulation. So in cases of lifelong anticoagulation, there is increased risk of bleeding, okay? So these are the risk versus benefit ratio. You need to remember the target INR. Like in the aortic, the target INR is a bit less compared to the mitral. Congenital aortic valve. Okay, atrial septal defect. I'll just try to draw down a picture. So any defect that occurs in this intraatrial septum, this is known as the atrial septal defect, right? So in the intraatrial septum, there is a bit of dent. In all of us, when we were babies, we had foramen ovale, right? In patients, when does it become pathological? Right after birth. If the foramen ovale is not closed, then that is known as the patent foramen ovale. So what's the difference between a patent foramen ovale and an atrial septal defect? Can anybody tell me?
Patent foramen ovale gets closed by the maximum 1 year of age, but mostly it gets closed, and ASD it doesn't get closed automatically.
Right, but in patent foramen ovale, if it doesn't get closed, that is known as the pathological.
BSD.
That's why it's known.
Yeah.
Okay, so the patent foramen ovale, yes, I appreciate that. Yeah, foramen ovale is a physiological thing. It will eventually close up, okay? But the term patent foramen ovale, that means like even after beyond 1 year, the foramen ovale will not get closed, okay? So that's known as the patent foramen ovale. It's more commoner in female compared to male. Same goes for ASD actually, although nowadays they're saying that male-female incidence is quite similar. The other difference is in patent foramen ovale, there will never be equalization of the pressure between the right atrium and the left atrium, okay? But in ASD, there is equalization of the pressure between the left atrium and the right atrium. So in left atrium, we know that the pressure is more compared to the right atrium, right? Because the systemic circulation is related to the left side and the pulmonary circulation is related to the right side. So obviously the left heart pressure is more compared to the right side. So because of the pressure gradient, the blood will be flowing from the left atrium to the right atrium, right? If the ASD is big, or over the time, there will be equalization of the pressure. So, but in case of patent foramen ovale, it's such a tiny defect. So blood will constantly go from left to right, but never from right to left. So there will never be a chance of equalization of pressure in case of a patent foramen ovale. And risk of systemic emboli like stroke is common in both patent foramen ovale or ASD, but as the pressure gradient is more in patent foramen ovale, That's why there is more risk of systemic embolization. Just remember these two lines. Okay, so in patent foramen ovale, never equalization of pressure between the left atrium and the right atrium, and there is more risk of systemic emboli like stroke or transient ischemic attack. All right, so any intraatrial pathology, better way of detecting this would be transesophageal echocardiogram. So this is like a very much similar procedure like an upper GI endoscopy. So the probe, which we usually, put on the chest in case of a transthoracic echocardiography, the probe will actually be placed like in endoscopy procedure through the mouth. And then it is passed down the esophagus, and from the esophagus, the probe is moved on the surface of the heart to see the interatrial or the whatever the backward pathology might be from the, like the base of the heart. The base of the heart lies in a bit slighted, tilted way, a bit more posteriorly. So that's why in order to properly visualize this, sometimes when we go for the transthoracic echo, you cannot move the probe that much well. So you might actually miss some pathology in maybe in the base of the heart or in the interatrial septum. So that's why you go for the transesophageal echocardiography to confirm. Varieties, okay, plus minus. Secondum is more common than the primum. I've already said that. In both cases, there will be right bundle branch block, but in case of secondum, there will be right axis deviation. And in case of the primum, there will be left axis deviation, okay? All right, next topic. VSD, just go through this topic, not that important. Just remember, if any of these type of congenital heart disease, if there is pulmonary hypertension develops, then and a woman wants to get pregnant, this is the single most contraindication of becoming pregnant, okay? If there is pulmonary hypertension, pregnancy is obviously discouraged, okay? Eisenmenger reversal of Shan, blah, 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 we know about this. Doctors are versus. All right, and go through the components of the phallus tetralogy, okay? So sometimes they might mess up with the word, like instead of right ventricular hypertrophy, they might give you like left ventricular hypertrophy. Instead of right ventricular outflow tract obstruction, they might give the left ventricular outflow obstruction. So be very much, VSD and overriding aorta will not be replaced with similar sounding words, but right and left pathology, they will easily mess up. So try to focus on that. And Epstein anomaly. Just remember two things. Combination of two things, okay? So what happens is Epstein anomaly is that the tricuspid valve, so if this is the level, this is the normal level, right? So the tricuspid valve is separating the right atrium from the right ventricle. In case of Epstein anomaly, this valve will be placed in a lower way. So this entire thing becomes the right atrium, and this tiny portion is the right ventricle. So this is known as the atrialization of the right ventricle. And because of this, there is some conduction abnormality in the form of WPW syndrome. And there is features of tricuspid regurgitation, okay? So if any patient you get tricuspid regurgitation with WPW, think of Epstein anomaly. All right, I think I'm done with our session today. I took a lot of time in terms of the physiology. Apologies for that. This is never an interesting topic. And I would actually advise you to go through these topics once you're back home. Just to summarize whatever we have discussed so far, cardiac action potential, especially plateau, do not forget about the calcium. Number two is that what different waves of the JVP signify, quite important. Different types of pulse, especially collapsing pulse. And it's important, as well as bisphereans, pulses alternans. These are important ones, okay? And then ECG finding, very important. Prolonged PR interval, short PR interval, only one thing, which is, Dr. Forkan, short PR interval, WPW syndrome, very good. Changes of hypo and hyperkalemia ECG changes, this is important. And first degree heart block, which is prolongation of the PR interval, causes for that. Complete heart block, very, very important. Which one is the first investigation you'd like to do? ECG. Okay, very good. And irregular JVP, irregular Canon A wave signifies complete heart block. Very good. And then that's all. That's all pretty much about the cardiac physiology. And then infective endocarditis, the criteria and the treatment protocol and investigation dilemma. Just weigh out your pros and cons, and then sometimes try to get the vibe from the stem. Like after reading the stem and the options, sometimes you'll be like, okay, actually they're probably going for the blood culture. Okay, actually they're probably requiring echocardiogram from me as the answer. Okay, so try to feel the vibe from the question. And also treatment option and the organism, these are very important. And okay, just go through once about the Jones criteria for the rheumatic heart disease or the rheumatic fever. And from the different type of valvular pathology, aortic stenosis is the most important, as well as indication of surgery in mitral stenosis, that's also important. And from the congenital heart disease, I would say ASD is important, VSD plus minus, not that important. Phallostetrology, and mitral valve prolapse association. These are the important topics, okay? All right, so do you guys have any question for me? Anyone from online or from in person? Any question for me? If not, then I will just ask maybe 5 to 6 questions, and then you can go, okay? All right, so.
One question.
Yes.
One question for my clearance that blood culture sample to collect 12 hours ago. এটা আমি তিনটা স্যাম্পল যে আমি তিনটা কি মানে 12 ঘন্টা পর পর নেব এরকম
Actually, it depends on different trust. In NHS, it depends on different trust. Some trusts prefer to take the 2 blood sample right away, and then the third sample to be taken 12 hours apart. And in our medical college, what they do is like they do 1 sample right away, and the next sample 12 hours apart, and the third sample 12 hours apart. Okay, so it depends from trust to trust and from hospital to hospital.
30 minutes apart needs to be sample.
30 minutes apart. Okay, maybe that was an emergency situation. So maybe emergency call, desperate times needs desperate solution. Maybe that's why she went for that. But it's ideally 12 hours apart. Okay. Okay, so I'll, Dr. Neha Singh, are you there?
Yes,
Hello?
ma'am.
Okay, so the first question is for you, okay? So can you tell me which one of the following would not be considered a normal variant on the ECG of an athletic 28-year-old man? Did you get my question? Not a normal variant of ECG finding in a 28-year-old athletic man. Number 1, Wenn-Quebec phenomenon. Number 2, sinus bradycardia. Number 3, junctional rhythm. Number 4, first-degree heart block. Number 5, left bundle branch block.
Hello. Sorry, I did not unmute myself. What was the third option, ma'am?
Oh, okay. Third option was junctional rhythm.
I think the junctional rhythm, ma'am.
Okay. Anybody would like to weigh in? Left bundle branch block, exactly. I have said in my previous lecture, like left bundle branch block is almost always pathological, okay? So it's never a physiological finding. Okay, no problem. You'll get the next one. So Dr. Furkan, all right, the next question is for you. I will try to give you something like a bit more straight cut. Okay, the stem is actually a bit elaborate, but I think you're going to get the diagnosis, okay? So a 45-year-old woman suffered from a sudden onset central severe chest pain, okay? And ECG has been done. It showed ST segment elevation. Troponin is slightly raised, okay? Troponin is not that raised. She was rushed to the emergency invasive angiogram, but this revealed slight wall irregularities with no luminal obstruction. So they did not find any clot in there. Okay, Subsequently, a cardiovascular MRI or a cardiac MRI was done, which showed apical ballooning of the myocardium resembling an octopus pot. She did not have any significant past medical history. There is a family history of premature coronary artery disease. Her partner recently passed away of a prostate cancer. So what is the most likely cause of the ST segment elevation? Number 1, coronary artery disease. Number 2, Takotsubo cardiomyopathy. Number 3, left ventricular aneurysm. Number 4, okay, this is the same, hypertrophic cardiomyopathy. Which one?
D.
Exactly. What was your clue? If there is a single clue that you have used to come to the diagnosis.
Cardiac, apical.
Apical ballooning, yes, very good. And the other one was there was an emotional stress here, right? Her partner recently passed away. So that is Takotsubo cardiomyopathy is also known as the broken heart syndrome. Okay, so very good for picking this up. All right. Okay, this one's for Dr. Deep. Okay, I'll get, since they're joining us from the very first class, I will try to like ask them a bit later on. So Dr. Deep, this one is your question. 60-year-old man presents with increasing shortness of breath on exertion, okay? During the examination, a third heart sound is heard. Examination of the respiratory system is unremarkable. So which one of the following is the most consistent with the finding? So what do you think the cause might be? Number 1, dilated cardiomyopathy. Number 2, hypertrophic obstructive cardiomyopathy. Number 3, atrial fibrillation. Number 4, mitral stenosis. Number 5, normal variant. Yes, S3. This one's a bit tricky. I know you guys already know, like this is not I have discussed. I've discussed something else. But can you correlate what I've discussed with the options that is given to you?
Could you repeat the options?
Yes, of course. So in the chest examination, you did not find any findings, okay? The patient has sudden severe central chest pain on exertion. You can only appreciate a gallop rhythm or the third heart sound. So what comes in your mind? What's the diagnosis? Without going through the other options, what does it mean? Heart failure, okay, that's very good. Now the options are dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy, atrial fibrillation, mitral stenosis, normal. Very good. Yes, that's basic common sense, right? Because in hypertrophic obstructive cardiomyopathy, yes, exactly, a bit younger age, as well as you would find something else, right? Other physical finding like jerky apex beat or maybe double impulse apex beat or something like murmur of mitral regurgitation or maybe sometimes aortic stenosis murmur like presentation you would be able to pick up from the precordium. So only with third heart sound in an elderly patient, you're thinking this is a case of heart failure. Commonest causes dilated cardiomyopathy. Okay, very good for thinking that. All right, next question. Okay, this one is for Dr. Kobir, okay? Dr. Kobir, so can you tell me a 45-year-old man presents with chest pain and breathlessness on exertion, okay? On examination, he's bradycardic with a rate of 31 beats per minute. You notice an irregular canon A wave in the JVP. So what underlying diagnosis is associated with this type of JVP waveform pattern? Do you need the options? Okay, so chest pain, shortness of breath on exertion. Patient is 45-year-old man. Examination, bradycardia. Rate is 31 beats per minute. JVP is irregular canon A wave. So do you have any diagnosis for this? Okay, I'll tell you the options, okay? First one is complete heart block. Second one is ventricular tachycardia. Third one is atrioventricular nodal reentrant tachycardia. Fourth one is tricuspid stenosis. And fifth one is atrial flutter. Tricuspid stenosis. JVP is irregular. Complete heart block, exactly. If you just forget about all the things that I've mentioned in the stem, if you just focus on the irregular canon A wave, that only signifies one thing, and that is complete heart block. Okay, thank you for taking this question. All right, so Doctor, I'm sorry, in the first day I have very difficult in, like Dr. Ovijicha, right? Okay, so this question is for you. So which one of the following feature is not a part of the modified Duke criteria used in the diagnosis of infective endocarditis? Okay, so you have to find out that which criteria is not a part of the modified Duke criteria. Okay, so the first one is fever more than 38 degree, positive molecular assay for specific gene target. Number 3, indwelling central line. Number 4, intravenous drug use. And number 5, Janeway lesion. Positive molecular assay. Okay, so actually, I'm sorry you got this wrong. The answer is actually indwelling central line. I'll tell you why. Because positive molecular assay, that means blood culture or any type of assay, like could be PCR or something like that. So you're basically detecting the culture organism. All right, so this one was a tricky. So I've just told you, like you already know everything, okay? But the RCP will play tricks with you, like maybe just rearranging the words a bit or something like that. Okay, so I just have like 2 more questions since Dr. Avijit and Dr. Neha Singh for them. So Dr. Neha, this one's for you, okay? Dr. Neha, can you hear me?
Yeah, ma'am.
All right, okay.
Yes, ma'am. Yes.
Okay, so okay, this question is for you. A 65-year-old man is found to have an ejection systolic murmur and a narrow pulse pressure on the examination. He has experienced no chest pain, no shortness of breath, no syncope. And echo confirms aortic stenosis and shows the aortic valve gradient of 36 millimeter mercury. So how does the patient should be managed? 1, routine aortic valve replacement. 2, urgent aortic valve replacement. 3, anticoagulation. 4, aortic valvoplasty. 5, regular cardiology outpatient review.
Option A.
Okay, routine aortic valve replacement. Is that your answer?
Yeah.
Okay, so actually, okay, Dr. Ovijit, can you tell me?
Yes.
Patient is 65. Sorry?
I say
Dr.
regular
Ahsan.
cardiologist. Yeah.
Yes, exactly. Oh, Dr. Ahsan, you're here. So yes, very good. You got this right. So the patient here is not having any symptom, okay? And the gradient is less than 50 millimeter mercury. So that's why no need to go for the valve replacement. The patient is asymptomatic, just follow this patient up. That's the answer, okay? No problem. You'll be able to get the other answers, I'm pretty sure. So,
Ma'am, actually, I had used the middle session after break because I had got an emergency in the hospital. So just missed.
okay, all right. No problem. I'm just happy that you're attending the class and try to, like go through these topics back in your home. I'm pretty sure that you'll be able to, like find it. So Dr. Ovijit, the last question is for you. So one of the patients who has a family history of Marfan syndrome has recently been diagnosed with this condition, okay? So what is the most important investigation to monitor their condition? A patient has been diagnosed with Marfan's, okay? So what's the single most important investigation that you would like to do to keep him under follow-up? Number 1, serum urea and electrolyte. Number 2, echocardiography. Number 3, spirometry. Number 4, electrocardiogram. And number 5, DEXA scan. Yes, very good. Because cardiovascular mortality is the most common cause of death in Marfan patient. All right, that's pretty good. Okay, Dr. Ahsan, would you like to participate in one question?
Yeah.
All right, okay. So this one question is for you, okay?
Yes.
So a 45-year-old man who's known to have Marfan's, this is also from Marfan's, presents with a low back pain, has been present for a few months now, and this is associated with headache, leg pain, and intermittent episodes of urinary incontinence. What is the cause for this? Number 1, depression. Number 2, spinal stenosis. Number 3, leaking aortic abdominal aneurysm. Number 4, multiple sclerosis. Number 5, dural ectasia.
Mm,
In a
Can you
Marfan
repeat?
patient.
I think, yeah. Please repeat this question again.
Okay, so a Marfan patient presented with low back pain, okay? And he also has headache, leg pain, intermittent episodes of urinary incontinence. So what do you think the cause might be?
I think spinal stenosis.
Spinal stenosis, okay. Well, spinal stenosis can cause this type of similar symptoms, I agree. But then again, with the background of Marfan's, you have to consider dural ectasia, okay?
Oh, yeah. Yes.
Yes, exactly. All right, no problem. Okay, I'll just ask you another question. Okay, a 62-year-old female with a history of mitral regurgitation attends her dentist, who intends to perform dental polishing. She is known to be penicillin allergic, okay? So which antibiotic prophylaxis or what type of prophylaxis against infective endocarditis should be given? 1, oral doxycycline. 2, oral erythromycin. 3, no antibiotic prophylaxis. 4, oral ofloxacin. 5, oral clindamycin.
I think I clindamycin.
Clindamycin, okay. Anyone from the
Oh, yeah.
no antibiotic prophylaxis, exactly. Because I've said that if the patient has rheumatic heart disease, don't bother about giving antibiotic prophylaxis. If the patient has previous episode of infective endocarditis before, then go for some sort of antibiotic, okay? So actually it was a bit tricky here because the mitral regurgitation kind of gives you away, like you're thinking, oh, we might need to be consideration of some sort of antibiotic, but no, that's not the case here, okay? So, okay, thank you all so much for participating actively in my session. Tomorrow we will go through the a bit more complicated ways, but I will try to make them a bit more palatable to you. All right, so take care, you guys, and do, you know, like go through these topics by your own, back in the comfort of your own home. All right, so thank you, take care.